Good morning, everybody. I'd like to welcome all of you to the Health Service Committee and thank you all for being here. I'd also like to thank everybody for their interest in the University of California. And we're now going to begin with public comment, and we have quite a few members of public comment. And we very much appreciate all of you being here, and we appreciate the observations and opinions that you provide. We feel that it is very important for us to hear from all of you and for the members of the public in considering issues related to the University of California. So I'm now going to ask Secretary Ann Shaw to review the guidelines.
Thank you. So as Chair Lansing indicated, we have about 20 individuals who signed up to address the committee this morning. Each of you will have up to a minute to address the committee. One of you has two colleagues pooling. The person who has pooled time will get 2.5 minutes. So I'm going to call about 5 or 6 people at a time. Once I call your name, any order you speak in is just fine. Please just identify yourself before you begin. To hear from as many speakers as possible, the Regents do not use these public comment periods for an exchange with speakers. Any questions that result from your comments will be referred to appropriate staff. Written comment is also important to the Regents. You may give any materials that you've brought with you to myself. I'll come and get them. Those materials will be available to the Regents for the duration of the meeting. Also, if you don't finish your statement and you have it in writing, you can give it to me. So I'm going to call the first 6 speakers. Once again, once I call your name, any order's fine. Just use the microphone up there. Also, I have a little timer on my cell phone, so when the minute's up, I'll let you know. Sadina Velik, Amanda Nguyen, Asha Issa, Ambika Verma, Tiana Telemaskova, and Neda Ashtari. Once again, any order's fine, and 1 minute for everyone.
We're going to be pooling our time, and then Asha is not present today.
Okay, so are you speaking for?
Together with Amanda. Me and Amanda are speaking too.
Okay, 2 minutes.
Okay. In 2009, UCLA opened its CPO food closet to help students dealing with economic hardships. 10 years down the road, food insecurity remains an issue amongst UC students. According to the UC Global Food Initiative in 2017, food insecurity occurs among 44% of undergraduates and 26% of graduate students. A significant amount of students stress about where their next meal will come from, leading them to underperform academically and strain their mental health. Even more concerning is the fact that food insecurity disproportionately affects UCLA's minority populations, such as African Americans, Latinx, American Indian, and LGBTQ members. Food insecure students also spend more time working and commuting to school than food secure students who spend more time on their studies. No student should have to pick between working multiple jobs to keep themselves full and their education. Although the UCLA Community Programs Office has done a tremendous amount of work in restocking the closet and establishing its presence in the Students' Activity Center since its conception a decade ago, much more should be done to expand the food closet. The issue at stake is the proportion of the closet and its inability to support a population of over 30,000 students. By noontime, as I've witnessed after entering the building, virtually all the canned goods are gone, and the best option left are condiments and recipe enhancers such as tomato sauce.
A petition launched this past weekend by UCLA's USAC General Representative 3 office amassed over 400 signatures thus far. UCLA students deserve the right to not be compelled to form a queue outside the food closet at its 8 a.m. opening time in fear of arriving too late. The 50-square-foot food closet space must be remodeled to be furnished with more healthy and nutritious food. The UCLA administration must contact outside entities and garner a continual supply of food to meet the demands of the student population. The problem is with the university's administrators who need to secure and allocate more funding to sustain its enterprise. Furthermore, if Chancellor Jean Block's UCLA Centennial campaign, which has fundraised $5 billion, is not being invested into improving the welfare of students, what good is such a fundraiser? How can we pursue our endeavors as an international leader if we can't take care of the community here, the foundation and future of UCLA's core values? How can we pursue innovation in education, service, and research if the backbone of our aspirations is suffering? As a #1 public university in America, this is unacceptable. How can we allow ourselves to be incompetent in terms of student services in comparison to UCI, which
I'm going to start the next person's time.
Can I finish the sentence?
Okay.
which hosts 10,000 fewer students and brandishes an 1,800 square foot bustling grocery store. Since we are the essential engine for progress, as quoted by Anthony Pritzker, who serves as the co-chair for the campaign, how can students uphold this when literally their fuel, food in this instance, is not accommodated sufficiently?
Hi everyone, my name is Ambika Verma and I am a second-year undergraduate student at UCLA. For those of you that are unaware of what is happening with Xtandi, Xtandi is a late-stage prostate cancer drug that was developed at the UCLA campus through taxpayer money from the NIH and Department of Defense. It received FDA approval in August 2012. There is currently no alternative effective therapy in use, and it is anticipated to be within the top 5 in drugs worldwide sales in 2020. UCLA held 3 patents on Xtandi after its development and licensed it to Medivation, which later entered into an agreement with Astellas, which was acquired by Pfizer. So now we have 2 big companies, Astellas and Pfizer, which are receiving huge profits from this drug created at UCLA. I work closely with an organization called UAEM, or Universities Allied for Essential Medicines, and UAEM, along with 55 other groups, including professors from Yale, Harvard, and Johns Hopkins, are urging the UC to drop a patent claim that I have in India, which is preventing the generic version of this drug and protecting profit. Pills cost pennies, but greed costs lives, and it is time that the UCs honor their commitments and hold global health as a fundamental human right, as opposed to a commodity sold to the highest bidder. Thank you so much for your time.
Hello, my name is Tiana Temelkovska, and I am a first-year medical student at the David Geffen School of Medicine. And I came to UCLA because I really believed in its mission. And this was confirmed for me during our first week of medical school, during which we had these mandatory sessions where we were told repeatedly about the school's values and mission to promote health equity and improve healthcare access on a global scale. But UCLA's patent appeal in India that Ambika just talked about for the drug Xtandi goes against all of these values. And not only does it contradict the university's own mission, but its own licensing guidelines as well, which state that, quote, in particular, healthcare products may not be readily available or accessible to the world's poorest people in developing countries. And as a public institution striving to uphold its public benefit mission, the university should consider such public benefit and broad societal needs when developing licensing strategies for these technologies. Yet UCLA's licensing with Xtandi goes against all of this.
Time.
So, one last sentence.
Okay.
So we ask that UCLA drop this patent appeal in India and open up negotiations between the UC and pharmaceutical companies to students involved in this cause, as well as representatives from industries such as Doctors Without Borders, the Medicines Patent Pool, and Universities Allied for Essential Medicines, who have experience negotiating these kinds of licensing agreements.
Should I start?
Yeah.
Thank you all for having me here today. My name is Neda Ashari, and I'm also a medical student at the David Geffen School of Medicine. I became involved with Xtandi because it's an issue really close to my heart. My mom was first diagnosed with metastatic breast cancer when I was 4 years old, and 8 years old when Anthem Blue Cross dropped her health insurance coverage. For the next several years, I would come to see that in reality, the entire family had cancer. My dad worked tirelessly to cover the out-of-pocket medical costs, with single shots of chemo often costing thousands of dollars, but eventually lost his business, lost our home, and separated my mother. I was 15 when I became her primary caregiver, and 16 when we were told she needed immediate spinal surgery to live. For months, I battled with insurance companies, having representatives explain it's just the policy and that their hands were tied. And when I lost her on May 15, 2012, the worst part wasn't saying goodbye to the woman who gave me life and love. The worst part was knowing thousands of other families would inevitably go through the same. And I was right. When I urged John Mazziota, Jan Napolitano, and the UC system to drop the Xtandi lawsuit, I keep hearing the same claims. Our hands are tied, and we don't want to be martyrs. But for one moment, can you step outside yourselves and imagine having to choose between life-saving medicine and the roof over your head?
Time.
Can you imagine the guilt you'd feel if your children lost their home because of the medicine you needed to stay alive? That's what my mom did. That's what my family endured. But this doesn't have to be the case, and you do have the incredible power to speak for those who can't speak for themselves. I'll end with my mom's favorite quote from our bedtime story, Stone Fox. If there's a will, there's a way. It's in our hands to find it. Thank you.
Thank you. Next, Arden Dressner-Levy, and Arden will have 2.5 minutes because 2 colleagues have pulled to her. Claire Fieldman, Kamyar Fights, Josh Lyda, and Malia Lupe Nye. A reminder, Arden gets 2.5 minutes and the others 1. Go ahead.
Thank you. Hi, my name's Arden. I'm a second year here at UCLA, and I'm here today to talk about CARE, the Center for Assault Resources and Prevention, and the inadequate resources that students currently have on campus. So as a freshman at UCLA, I learned that CARE is supposed to be there for you if you are sexually assaulted. This year, after embarking upon some research within USAC to work on some projects about sexual violence, I decided I wanted to consult with the leadership at CARE. It took me 3 full months spanning 2 quarters to set up a meeting. I can only imagine what that would have felt like if I was seeking counseling for rape instead of just seeking information. At my meeting, I found out that there were only 2 advocates at CARE who are actually trained to walk survivors through their options after they are assaulted. If you take a guess in your head quickly, how many cases do you think each of these advocates have? Think about it for a second. According to the director of CARE, each advocate currently has a caseload of over 400 students. To have only 2 trained professionals who can give trauma-informed help to a survivor of sexual assault at a school of about 45,000 students, where more than 1 in 10 of all students will most likely be assaulted in their time here, is criminally irresponsible. We deserve better resources, and CARE advocates deserve more support. For reference, most social workers working in child protective services with cases of abuse and neglect are recommended a caseload limit of 12, incomparable to the caseload of 400 that our 2 CARE advocates currently have. CARE is so overwhelmed that they cannot even advocate for more funding, so I'm here to do it for them. CARE recently was blessed with a small bonus in funding, which will allow them to hire 2 new staff members. However, that's not even close to enough. Please, as officers who are in positions of power and are much more capable of doing this than I am as a student, do take the initiative to secure or allocate more permanent funding for CARE and its partner and similar initiatives on UC campuses. The work that they do is invaluable and should be supported through more money that will allow for the hiring of more CARE advocates. Thank you for your time.
Good morning. My name is Claire Fieldman, and I have the privilege to serve as UCLA's USAC president and chair of the UC Council of Student Body Presidents for the 2018-19 year. I am here today to urge the regions to dedicate more funding to CAPS and CARE system-wide. Mental health is an issue incredibly close to my heart, as I personally have struggled with an eating disorder, depression, and anxiety. I've unfortunately lost 2 close friends to mental health-related suicides. I have witnessed many of my peers at UCLA and across the UC struggle with mental health, skipping classes, taking quarters off, and wrestling with the less than ideal infrastructure of CAPS. Students often have to wait months for their appointments, become discouraged after calling numerous off-campus providers that refuse to see them or take their insurance, or do not have access to clinicians that share their identities. Further, mental health often intersects with experience of sexual violence and sexual harassment. In the era of Me Too, reports are increasing exponentially. UCLA's Title IX office saw 90 reports of prohibited conduct in January alone. This is completely unacceptable for the #1 public school in the country. And we are not alone. Other UCs have similar or even worse situations. In a federal political climate that trivializes mental health and sexual violence, we at the UC must take concerted, intentional steps towards supporting our students and setting the example for higher education nationwide. Thank you.
Hello, my name is Kamyar Faze, and I'm a 3rd-year transfer student here at UCLA. A number of weeks ago, my girlfriend, who also attends UCLA, was experiencing lightheadedness and severe nosebleeds. I continually asked her, and even begged her at one point, to go to the Ash Center, where she could have hopefully received the medical attention she required. She told me no, for the simple reason that she did not want to spare the expense. She had opted out of purchasing U-Ship due to the fact that she could not afford the few extra $1,000s a year. Keep in mind, this is a person who is completely financially independent, a person who pays for her own living, tuition, groceries, gas, phone bill, etc. At 21 years old, she is forced to carry this burden on her back, not to mention along with all the extra weight which come from classes and extracurriculars. This, in turn, contributes to increased levels of stress, anxiety, and depression, something which is, of course, easily treatable if one has the resources available to afford such treatment. My girlfriend is also someone who is food insecure and does not always necessarily know which meals of the day she will have the luxury of eating, if she has even that. She is not an anomaly. We know there are thousands of others across the UC system placed in the very same situation on a daily basis.
Time.
At a schooling system as prestigious as that of the UC's, students should not be worried about their mental health, their physical being, nor should they be worried about whether or not they will be eating today. The walls which surround us in an educational institution such as this should be there to safeguard us from such atrocities. Thank you.
Hello, my name is Josh Leda. I'm currently one of the co-presidents and outreach coordinator of the American Indian Student Association here on UCLA campus. Before I begin my statement, I don't know I have a lot of time, but I'd like to acknowledge that UCLA is a land-grant institution, and we wouldn't be here without the graciousness of the Gabrielino Tongva people who allow us to continue this institution here at UCLA. And I'd like to bring up the 30-meter telescope that is being built on Native Hawaiian lands. It is currently going to be placed on a very religious site of Native Hawaiian people at Mauna Kea. And I know that the UC system is currently promoting this telescope, and quite frankly, it's a little bit disrespectful to the Native Hawaiian people, considering the fact that pretty much all UCs are land-grant institutions and have been built with the acceptance of all of the indigenous peoples whose lands the UCs reside on, and the fact that the UC system is now allowing to have another telescope being built on another indigenous people's lands is kind of disrespectful. So we are going to be starting to advocate against this. So yeah, thank you.
Thank you. Is Malia Nye here? Okay, thank you. So we have 5 more speakers. Papu Togafau, Jamie Knurk, Sunny Pointer, Atreyi Mitra, sorry if I can't read your writing, Michael Kahn, and Rob Kadoda.
Hi, everyone. Oh, there we go. My name is Jamie. I'm the undergraduate external vice president at UCLA. Hello again. So I am here for my original comment in regards to building the telescope on native land. I first of all want to say that this is unacceptable and back up what Josh said. It's the same issue we talked about with native repatriation in AB 2836 back in the summer. Abuse of native land and bodies is never acceptable, and academic advancement does not happen when it means the erasure and violence against the community. So that's my first thing. The second thing that I want to talk about, which came up at the UCSA board meeting this past weekend, is the lack of compliance among faculty with respecting gender pronouns and names. This is required by law and is considered a form of discrimination if it is not respected. And in our system-wide conversations with LGBT centers across the system, one of the major things they talked about with us is this. And as a gender fluid and queer student, I have professors who make cringeworthy and misinformed statements during class. The other day, one of them went on a tangent about how he's usually really good at discerning between men and women based on their appearance. In Westwood, I was interrogated about my gender because I pass as male on my driver's license, and they didn't believe that it was mine.
Time.
And this is not something that students should face in a classroom, and is something that needs to be taken seriously, and we need to make sure that professors are not using dead names or misgendering their students. Thank you.
Good morning. My name is Sunny Pointer. I'm a third-year law student here at UCLA. I have a master's in mental health counseling, and I'm deeply concerned about the lack of quantitative research on sexual violence on the UC campuses. There's been a dearth of research on this issue, and you've already heard today about how CARE is underfunded, how there are a significant number of UC students, and especially UCLA students, who will experience sexual assault and may not be able to access resources. Quantitative research on sexual violence informs policy and informs how we make these decisions. It helps us know who is experiencing sexual violence. It helps us know where it's happening. It helps us to develop prevention measures and care for those who experience these things. However, The My Voice survey at Berkeley has been the most comprehensive undertaking yet, but it has not been replicated at any other UC campus. And I believe that you should urge the UCs to undergo this quantitative research, take it into account, and care for our students. Thank you.
Hi, my name's Atray, and I'm here today on behalf of Bruin Consent Coalition, formerly 7,000 in Solidarity, an entity that works very closely with CARE to urge the regions to give more funding to CARE so they can get another advocate so that they can better support survivors. When all the UC campuses were mandated to have a CARE office in 2015, UCOP gave them 3 years of funding. It is now 2019 and the CARE offices are struggling. They're forced to apply to grants such as the Violence Against Women Act, something that may no longer be an option to just support their students. From 2015 to 2016, CARE had 207 clients. From 2017 to 2018, there were 388 clients. And from 2017 to 2018, CARE had 770 clients. And all this for 2 CARE advocates. These increasing number of clients exemplifies a need for this service. While UCLA has this issue, it's not just our campus. In fact, Merced has 2 CARE advocates. Santa Barbara, Santa Cruz, and Berkeley all have 3. I have come to believe that the best form of sexual violence advocacy comes from supporting those who already do the work. And Janet Napolitano herself has time after time reaffirmed her commitment to survivors, especially during this tumultuous administration. So in sum, I urge you to give more funding to CARE so we can get another CARE advocate, and because student health kind of depends on it. Thank you.
My name is Michael Kahn. I'm the secretary of the UCLA Bicycle Academy, and I'm here to remind the regents and the vice chancellors that transportation is an issue which is insufficiently addressed in the conduct of health policy and health provision. Healthy transportation, active transportation is something that should be much more in the center of your work. And I want to talk about 1, 2, 3 things that are happening and that I'm involved with currently that show where UC health is falling short. If you're opening a new medical premises anywhere in Los Angeles or anywhere within the system, you will use a lease template which comes from Sacramento, the Office of the President, and that lease template will not reflect best practice regarding green leases and sustainable transportation. It will not include bicycle parking, it will not include electrical vehicle charging points, and worst of all, it will include bundled parking. These are structural... Time is over?
It is. Do you have one more sentence? Short?
I want to say that we're working with the Los Angeles County's Medical Association to arrange a meeting where we put together bicycle advocates and medical providers with the support of UCLA Health, and we're going to have a discussion how the community health needs assessment process can be used to support active and healthy transportation at your locations. Thank you.
Hi, good morning. My name is Rob Cadota. I'm a 28-year employee of UCLA and will be retiring in the near future with reasonable financial and physical health, and thank you for that. I appreciate the students' voices this morning and sharing their cares and concerns about health issues. I'm also involved in bicycle advocacy and want to encourage you to recognize the special opportunities that Vision Zero, an international program to reduce fatalities, is happening, and encourage you to take a look at that. I think also the Expo Line and Purple Line expansion for the city are incredible opportunities for the UC and the state of California to make a difference. The Olympics are as a special opportunity to make a difference and make a statement about what a caring and concerned community we can be. As you seek grand health initiative policies and facilities, know that you have partners like me volunteering in our communities, helping our neighbors make healthier and safer decisions by handing out bike lights to those riding without, hosting safe cycling workshops, tuning up bikes at our local YMCA and farmers markets. I encourage your partnership in making our health facilities as welcoming and positive as possible.
Thank you. Those are all of our speakers this morning.
Again, thank you for your comments. We really appreciate you taking the time to be here, and we take the issues that you have raised very seriously. Before I turn this meeting over to Dr. Stobo, I want to welcome all of our committee members to what is our first meeting of 2019. And I'd especially like to welcome our two new committee members, Regent Guber and Regent Park. We're really happy that you have joined us. And you will recall that the regents approved amendments to the committee chair to allow 2 additional regents as committee members, and also to provide for 3-year renewable terms, instead of the 1-year renewable term for all other committees. That means that Regents Guber and Park are members until at least 2021, which is good news. We again have a very full agenda before the committee today, and I really appreciate everyone starting almost an hour earlier. Several items on the agenda are in response to requests that members of the committee have asked. So I thank Dr. Stobo and his team for their responsiveness. We will hear updates on student mental health services and the university's efforts to address concerns regarding physician well-being and burnout, among other important topics. So I think I need a roll call, since we have some people on the phone, and then I'm going to have approval of the minutes.
So do you want me to do one roll call for both?
Sure.
Okay, so this will be roll call and also approval of the minutes for December open session. So this will be all committee members: Regents Blum, Guber, Kiefer, here. Lansing,
here.
Malkarishian, Napolitano, here. Newsom, Park, here. Sherman, here. And Zettel. Here. You have a quorum, and the minutes are approved.
Patty on the phone?
No.
Okay. So we have a quorum. Great. All right, so now I'm going to turn it over to Executive Vice President Stobo for his remarks.
Thank you very much, Madam Chair. This is the usual financial summary, represents FY19 December year-to-date, first 6 months. The first line is a modified operating income before health system support for 18 and 19 comparison. Remember, the modified operating income is income that includes expenses of cash and non-cash for the pension and expenses of cash for the other post-employee benefits. It does not include the non-cash obligation as part of the other post-employee benefits. The first line is before health system support. The second is the modified earnings before interest and depreciation, EBITDA. The days cash on hand, remember our threshold was 60. Everybody's above the 60 days cash on hand threshold. And debt service coverage is, we'd like to be above 3, and everybody's above 3. The difference in the operating income between 19 and 18 in some institutions has to do with larger than expected pension expenses. In one case, Irvine, for example, they have greater than expected income. That was a one-time payment for some supplemental payments that came along as part of Medi-Cal and other things. So the medical centers continue to have being a strong financial position, and I'll be glad to take any questions or comments, or any comments from the CEOs or the campuses. Okay. Okay. At the last meeting of the Health Services Committee, the issue of the follow-up for the advisory committee recommendation came up, particularly with regard to the recommendation around human resources and the use of career tracks that were part of UCSF. The issue was the career tracks at UCOP did not take into consideration the market around certain positions in the healthcare marketplace. positions that in the market required a competitive salary that was significantly above what was available through the UCOP market reference zones, the UCOP career tracks. There was concern raised about why the recommendation was not fully implemented. After the HSC meeting, Rachel Nava called a meeting of UC Health and Human Resources and the Chief Operating Officer's office. We met, discussed the issues, and it was actually a very productive meeting. HR indicated its concern over UCOP using career tracks from another campus, which might serve as a precedent for other campuses doing the same thing. And to avoid that, we agreed that the human resources would do two things. First of all, it would develop within the UCOP career tracks a set of tracks that was specifically for health-related positions. And it would do that by April 1. At last time we talked about 2 weeks ago or a week and a half ago, they were on track to do that. That is, by April 1, we will have within the Office of the President a set of career tracks that will apply to health-related positions within UC Health in the Office of the President. And that will satisfy, as far as I can tell, the issue that was raised or the wishes of the advisory committee. So that is going to happen. And in the interim, there will be special exemptions granted by Human Resources for salaries above what is present in the UCOP career tracks presently. So we'll do it by exception between now and April. After April, we will have the career tracks that apply to positions within UC Health that are related to health activities. So, Steve Lipstein, who was a member of the advisory committee, yes.
Yeah, Dr. Stobo, the reason this came up at the last Health Services Committee is within the strategic plan for UC Health, for the upcoming budget year, there are 65 full-time equivalent positions. Memory serves me correct, there are about 34 that are going to be inside the Office of the President and 31 that are going to be located on the campuses.
Your memory is correct.
Our concern was that in order for UC Health to be able to achieve the goals, the ambitious goals that are set forth in that strategic plan, it needs those 65 people. Can you, when we make this change on April 1st that you just described, can you give us some assurance that the 65 people will be on board within the budgeted time frame so that we have a fighting chance to achieve those goals?
Well, we'll talk about this when we get to the strategic plan. I can give you my commitment to do everything we can to make sure that we fulfill the plans that are outlined for the fiscal year 18-19. Correct? Yes, 18-19. Yes. So, yes. I mean, it is ambitious, as you point out. And we have had difficulty in the past with that ambition. But I think that after the meeting we had several weeks ago, following the last Health Services Committee meeting, it will be easier to do that within the Office of the President, particularly after April 1, when there exists a set of health-related career tracks. So I think the obstacles have been removed, Steve, from us to being able to do what's outlined in the strategic plan. So I am hoping that if we don't achieve our goal, it won't be because of obstacles in human resources, but it would be a failure of us within UC Health to deliver. Okay, then we'll go to the next topic, which is one of the major topics for discussion today, and that is the presentation of our 18-19 strategic plan. I'm going to ask Liz Engel, who is the Chief Strategy Officer, to come up here and do this presentation with me. Let's see, do we have a set of slides for the strategic plan? All right, let me go back to remind everybody, I'm sorry, are we getting a little ahead of the agenda? Did we have a consent item before this?
We had to agree on the UC Health Capital Financial Plan, which is a consent item.
This is a consent item. Remember, this came up as a discussion. We talked about this last
Right.
time, and you approved us doing this. And what it is that the capital projects outlined in the 1824 capital plan that have been approved by the full Board of the Regents will not come to this committee for approval unless they meet the exception criteria which are outlined in the item that's in the book. That is, if it's a new hospital, of course it'll come here. If it's a building that's related to health that is not in the 1824 capital plan, yes, it'll come here. So it's not that you're relinquishing any a prerogative that you should be concerned on relinquishing. Everything I will tell you of any project that's going to the Regents that doesn't come here. I'll inform you about that before it goes to the full Regents. So if there is a concern, that can be raised. And projects that apply to the exceptions that are outlined in the article in your book will come here before they go to the full board.
President Napolitano, you have comments?
Yeah, Jack, as described in the item, this is really to clarify and streamline the multiplicity of regental approvals necessary for capital items, i.e. that they were going for review and then approval to Capital and Finance Committee, and they'd also come to this committee, et cetera, and that was building a lot of delay into the process. So,
correct.
I think what is proposed here is a reasonable accommodation for this committee and for the Capital and Finance Committee.
No, you said it very well, President. That's the intent, but not to put anything by the committee that they shouldn't have purview over.
But actually, there's no one on the phone.
Well, but technically, I want to make sure, so.
Hadi, are you on the phone? Okay.
All right, so let's go to the strategic plan. Okay, all right, just to remind everybody that the challenges that face the divisional office, UC Health Divisional Office, and UC Health writ large, we're in a competitive financial environment where our reimbursements are declining, which is happening. And our commercial side is declining by 50%. Unpredictable health policy, and increasing growing market and payer expectations, where those who pay for health care, whether it be the individuals enrolled in health plans, employees, those employers of large self-insured health plans, the federal government, people who pay the bills, are expecting more and more for us to demonstrate the value they get for paying for those costs. There is enormous consolidation occurring all over the country in the healthcare marketplace. Mayo Clinic's expansion into Florida and into Arizona, for example. Hopkins expansion not only into Maryland, but also into Florida. UT MD Anderson setting up several satellite locations, including in San Diego. Kaiser expansion, and all these large systems that we're competing against make it clear that Size, solid financial performance, and increased emphasis on quality and accountability are the metrics for success. So remember, we are competing against systems that really are governed and organized as a system. We are organized and governed quite differently, but still expected to act as a system in the marketplace. The new environment requires scale, systems integration, agility, rapid strategic innovation. We all agree that to do nothing it will not work. It is an existential threat to all of UC Health. And that the divisional office and the office of the president, and this is the strategic plan and budget that we present this morning, applies to that divisional office. That the divisional office is a catalyst necessary to meet these challenges while maintaining the balance between the tripartite missions of clinical service, research, and education. The advisory committee also made a very important recommendation that was consistent with their understanding that we need to grow. If we're going to do all this and compete in the marketplace, that the divisional office needed to be larger than it is now, to have in it the individuals that could work with the UC Health out in the campuses and the medical centers, et cetera, to meet these challenges. Our budget previously was organized this way. The Health Services Committee and Board of Regents at the top, the Office of the President, and the Divisional Office. Then underneath that was support of the immediate office, some support from the health systems, and then support from health insurance premiums to support the administration for our self-funded health plans. And now all of our health plans are either self-funded or we share in the financial risk, with the exception of Kaiser. What the advisory committee recommended in order to let us grow, given the constraints that exist within the Office of the President, was to create a separate bucket called the UC Healthcare Collaborative. In that collaborative, there would be several different activities, all of which were designed to support the clinical mission of UC Health. And it would be supported by health system funds that would come through the campuses. And this would be the part of the budget that would be allowed to expand and grow with proper oversight. And proper oversight is by this committee, it's by the chancellors, it's by the chief executive officers, it's by the deans, and it's by the Executive Budget Committee, and finally the President, and then the full Board of the Regents. So it's a Health Services Committee, the full Board of the Regents, the Executive Budget Committee, the Chancellors, the CEOs, the Deans, and the President that have oversight for the budget. So there's plenty, from our standpoint, oversight provided and control over growth, budget, et cetera. But our budget will be two buckets, the so-called collaborative, and then monies that come to the Office of the President, supported from general funds that have been given to the Office of the President by the state legislature. And we will continue to use premiums to support the self-funded health plan. So that's the budgetary outline for support of our divisional office. Any questions about that? Okay. Now, I did, one point I forgot to remember is what we do on the collaborative side is guided by our strategic plan. That is, it's what we present is consistent with the strategic plan, then it's gone over the threshold and can be discussed. If it's not in the strategic plan, then it doesn't get across the threshold. And for it to be discussed and approved by anybody is going to represent some special exemption, which is very likely not to occur. So the budget that is part of the UC Health Collaborative has to be within the framework, or the programs, plans, and operations have to be within the framework outlined by our strategic plan. And our strategic plan was first put together about a year ago. It was recently refreshed and approved. Well, let me get to that in a minute. What we're going to present now is the strategic plan. We will show a budget at the end with FTEs at the end, and what we have been able to calculate is a return on investment at the end. This presentation has been given to several different groups with their approval. And those groups are the chancellors and the chief executive officers, the medical centers. It will be reviewed by the executive budget committee, I believe, this week. So before we start, are there any questions?
You know, I think, Madam Chair, I think it's when we talk about the executive budget committee particularly for newer regions, it's important just to outline always who comprise the executive budget committee.
Zoanne, do you? Yeah, EBC.
Members of the campuses, which includes the provost, the vice chancellor of planning and budget, the vice chancellor of administration, plus 2 members from the academic senate, the current chair and the past chair, and members of the office of the president of the
Okay. All right. Okay. So let's go and say Liz Engel, who Chief Strategy Officer, is here with me to go over these. Now, our strategic plan has 12 goals. When we refreshed it, we changed one goal, and that was goal number 12. We dropped a goal and added a goal, or we substituted, switched out goals. We're going to, on the left-hand side is a goal number. The ones that are shaded are the ones that we are going to present here. They're the ones that are included as part of the collaborative. The goals 1, 2, 3, 4, 5, and 11 are part of the collaborative. They're the ones that address issues at a system-wide level for the clinical enterprise, and are funded by monies coming from the health systems and the medical centers. Goal 6 is funded by health insurance premiums. Goals 7, 8, 9, and 10 are funded by what we call the core budget. Those are general funds that come to the Office of the President. Goal 12 is also funded by the core budget. Okay? The first goal is leveraging scale for value. This is our system-wide cost reduction goal. This includes 6 activities that are around procurement, revenue cycle, information technology, pharmacy, capital projects, and clinical lab. The goal here is to eventually achieve, on a year-to-year basis, $500 million in value through cost reduction, beginning in the year FY21. What it has been able to do in the past several years is to achieve, on a yearly basis, somewhere between $300 and $400 million a year in cost reduction across the system. And this is the goal that will be supported by the collaborative. Goal number 2, to develop and launch system-wide strategic initiatives. I'm going to ask Liz to go ahead and talk about this.
Sure.
Ms. Engel.
And thank you so much for the opportunity to speak to this. You'll see an overarching theme among all these goals, and that is to allow the UC Health Division to help coordinate and collaborate, facilitate coordination and collaboration among the campuses, to leverage our scale, to increase efficiencies, to improve patient outcomes, and to reduce costs. So goal number 2 is to develop and launch system-wide strategic initiatives. UC Health, as just described, has undertaken a number of initiatives to foster system-wide collaboration. However, The various efforts have often occurred in silos and haven't been coordinated and integrated, and work has often, to undertake new projects and initiatives, has sometimes been ad hoc. So the goal here is for a small strategic planning function in UC Health to convene and coordinate with campus leadership to reach consensus on areas of future collaboration. The goal is also to support analysis and execution of agreed upon projects and transactions. And the key example on the table right now is with respect to the President's recently announced Cancer Consortium. A burning issue for the med centers is how do we work collectively and collaboratively to address competitive threats? Where are the key areas for offense and defense where we can act system-wide or regionally?
Goal 3.
Oops,
Goal
I went
5.
to. Okay. Goal 3.
Goal 3.
Oh,
Goal 3.
We're missing a slide for some reason. Well, goal 3 is to establish a very small quality and population health management team in UC Health. This involves substantive expertise, leadership, and project management. This team will convene the relevant stakeholders at the campuses to agree upon targeted efforts where it's beneficial for us to collaborate as a system in our quality and population health management efforts. The goal here is to use our system-wide claims data and clinical data that are gathered currently in our health data warehouse. And importantly, the approach here is to build upon and complement the work that's already being done at the campuses. Why are we doing this? Each of the 5 medical centers and their respective faculty practices have differing approaches and levels of ability to measure quality, undertake population health management efforts, and take on risk. And by comparing standards of care and outcomes and other data, the idea is that our medical centers and our health plans will be better able to identify best practices within the system to better manage care and to ultimately improve outcomes and reduce costs. Keep going ahead, I apologize.
Okay. Wait, who's running this? Goal 4 is to improve system-wide financial analysis. Right now, each of the medical centers has a great financial bookkeeping, et cetera, and financial reports. The problem is we can't compare campus to campus. If you go in and look at the expense, a revenue bucket or an expense bucket from one campus compared to another, they're not comparable because the different items or different activities go into each of those buckets. So, and nor do we have a system-wide dashboard to look at financial performance, et cetera, in a standard way that allows us to compare campus to campus, medical center to medical center, health system to health system. So the goal here is to standardize the financial reporting so that we can do this comparison and establish a system-wide way of looking and comparing various activities from campus to campus, to have a system-wide dashboard. We are actually fairly far along on the first step, that is trying to standardize expense and revenue buckets from campus to campus. We hopefully will finish that within the next year or so, and then move on to the system-wide dashboard.
Goal number 5 is to establish a small team within UC Health that leverages our system-wide clinical and claims data to support a variety of other goals and initiatives across the system. These include quality and population health management, as discussed. That is the primary client of this center and the primary focus of the relevant initiatives. But the data team can also support our leveraging scale for value functions, our strategic planning, research, and even compliance efforts. This committee was briefed recently last fall by Dr. Atul Butte, who outlined some of the great work being done with the data in our health data warehouse, so I won't go into detail there. But I will say that the overarching goal of establishing this small team, this center, is to really provide broader insights locally at the campus level by offering a view across the system, to help the professional schools and medical centers do what they're already doing, but doing it better, faster, and more efficiently and in a less costly manner, and to help UC Health as a system determine what initiatives to undertake and to prioritize. So the last goal that we'll talk about in the collaborative is around more effectively influencing public policy at a system level. The goal here, number 11, is to establish a small policy team that will allow us to engage proactively and strategically regarding important health policy related legislation and regulatory activity, and also to more systematically inform the campuses of pending activity and engage them in the development of policy positions. The idea here is to start this at the state level. As this group well knows, there's a tremendous opportunity here with the new administration that is incredibly focused on healthcare, to engage proactively to identify areas of common ground, such as around Medi-Cal, drug pricing, and determine areas where we can collaborate and collectively influence policy. So that's the last piece here, and I think we can pause and see if there are any questions about the goals.
Yeah. Are there any questions about the goals before we get into the budget, FTEs, and ROI?
Thank you for that presentation. I have a few different questions. So first of all, is this a presentation that is also going before the full board?
We hadn't planned to take it to the full board. That could be done, but that wasn't within the plans.
I'm requesting it to the chair. My second question is in terms of the governance of the collaborative. Do you have a slide or something that you could show us visually in terms of the governance there?
Well, the governance is a little complicated in that there's the immediate office, which is the operating arm that implements the plan, the plans that are part of the collaborative. But the governance has to include the bodies that approve it. And as I mentioned, that is the chancellors of the 6 campuses that have health-related activities, they have approved it. The CEOs of the 5 medical centers, they have approved it. It has to be reviewed by the Health Services Committee. It has to be approved by the Executive Budget Committee that we just heard of is representation from the campus. Then it goes to the president for her approval. Then it goes to the full board as part of the overall UCOP budget. So while I said we did not plan to present this specific part only to the full board, our budget will go to the full board as part of the budget presentation later on in the spring when the full board considers the budget coming from the Office of the President.
You know, there's a clarification. I do think the strategic plan is required to go to the full board.
I'm sorry?
We're correcting ourselves. We just looked up the charter, and we are required to present this to the full board, so we would have done it. We made a mistake.
Okay, well then we ought to get it. We need to get it on the
schedule. It's required. It
All right.
says so on our charter.
So that, I think we were naming the approvals in terms of the actual strategic plan and the budget. I was asking more in terms of when there's specific decision-making, whether it's goal number 5 about improving system-wide financial analysis or establishing the system-wide data center. Is that what is the governance that controls?
The governance of that is implemented by the divisional office in the Office of the President. The office that I have purview of that sits within the Office of the President. But those who decide whether that goal has been met include the bodies that I indicated, predominantly the chancellors and the CEOs.
Okay, so what you're saying is that there is consensus among all the parties in terms of establishing it as a goal, and then there's the question of whether a certain goal has been met. Those are the
There
two
will be
points.
quarterly reports presented to the chancellors, to the CEOs, and to this board on the progress associated with each of these goals. So 4 times a year, you will have the opportunity, you along with the chancellors and with the CEOs will have an opportunity to assess whether or not the divisional office is meeting the benchmarks associated with the goal.
Okay, I thought that I had read in terms of the committee that it was annually, not quarterly, but if it's quarterly, I appreciate that clarification.
I'm sorry, Regent Park? It's quarterly.
It's quarterly to this committee, okay.
Yes.
Okay, my other question is perhaps about the financial estimates, and I don't know if this is the best place to raise this question, but some of these costs in terms of the system, the data warehouse, for instance, there's an estimated cost savings that are associated with some of these investments, correct?
Right, correct. Can we have a slide that'll go into that, to show that, but I just do not do it now.
Okay, that's fine. I'll raise my hand again when we get to that point.
All right, terrific.
Thank you.
Any other questions before we continue? Regent Settle and Regent Kiefer after that.
Thank you, and this might be better off for this question for the next presentation. But with regard to goals 3, 4, and 5, a lot of this is relying upon data, and I'm wondering how our software and our fintech, all of that, are we ready to implement these, or is this way down, the next couple of years, and a significant investment in budgetary resources to develop the technology to really extract from the data meaningful things that you can inform your decisions with regard to population health, with regards to
I'll ask Liz to comment specifically, but let me just say in general terms, these had to be implemented yesterday. We have, for example, in terms of the data warehouse, we have a resource, an enormously valuable resource in the data that's associated with 16 million unique patient records that are part of us, that are our patients, that have been collected, stored, ready for analysis now for a couple of years. So we need to implement these as quickly as possible before we're eclipsed by other systems that don't right now have the rich data source that we have.
Yeah, I'll probably not get this entirely right, Jack, but I think it's important for all of us, for me anyway, to keep in mind sort of the big picture here, this structure. As the university has grown, we've delegated more and more to the president's office, and the president has delegated more and more to the campuses overall. Tenure decisions and faculty members used to be done by our Board of Regents. We gave that up quite a while ago because we saw that that was something that could be done at the campuses. We have responsibility for the health system, which historically has been thought of as 5 different health systems, at least. And they have operated largely independently, appropriately. We have a change in the world today that requires us to be more coordinated. Our board has not been in a position to do the kinds of things, just whether it be tenure, or to measure the health systems, the different campuses. We've got lots of other things on our plate, and we don't have quite the experience we'd like to have to be looking at all of those systems at the same time. So in some ways, we've delegated this effectively to the Office of the President, but we've never created a group of people that could take on that responsibility of some oversight and the emergence of collaboration and coordination to compete with the market today. So in some ways, we are creating something in the Office of the President to match the responsibility that we've already assigned to the Office of the President, because we're not in a position to do it. Now, there's also, along with this, a little bit of tension between the medical systems in each of the campuses, and to the degree to which they are independent versus how they're going to be coordinated. So that's going on at the same time as we've sort of knitting this together. But I think to me, that's important context for this. And so when we talk about, who has authority, the regions ultimately have the authority, but we've delegated a lot of that to the Office of the President. I think in some ways we're giving the Office of the President the tools to do the job more properly. And as we move along, there'll be, little bumps and so forth with the campuses on how much coordination, how much collaboration, how much dictation. That'll be natural. But that's the way I look at this, and so the goals are being developed from the bottom up as much as the top down, because they frankly have to be, given the history and a slow knitting of a system to compete with the Kaisers and the rest of the world. If that's off, tell me. But
No, it's not, Regent Kiefer. But I think, in my view, when we reconfigure the Health Services Committee, it would be the Health Services Committee that would have that organizational and oversight purview that you talked about.
yeah, I agree. That's the other aspect of it, is a recognition that we need to focus more carefully on simply the health system by creating the Health Services Committee. But as we can see, the Health Services Committee can't get entirely into the weeds either. So
I'm sorry.
We can't get entirely into the weeds either at the Health Services Committee, so a lot of the things are being delegated, and a budget is being created for you to do the kinds of things you need to do so the Health Committee can be informed and make those judgments. But I agree with you. We created the Health Services Committee to get more specifically involved as opposed to the board.
But I would slightly, I was going to slightly disagree. I think what you're saying is correct, but I actually think it's being delegated to the Health Service Committee, when, with all due respect, even more than to the Office of the President, because that was the whole purpose of this committee, was to make sure that the CEOs could act nimbly and flexibly and not have to go through many, many layers. And so this committee was empowered, and if you read the charter, to really act within certain financial constraints within the rules of the regions, and to report back to the regions, and it actually freed up a lot from the Office of the President, which doesn't mean there isn't still a lot there. So I think that's really, it's this committee that has been empowered.
Yeah, I'm not talking about so much the governance at the board and committee. I agree with you, but to recognize that we're actually putting a budget in place, and that's what we're going to be talking about in a minute, for the Office of the President to do some of the work that we're asking them to do in coordinating and collaborating with the campuses.
Steve Lipson?
Yeah, I think you both are correct. If this Health Services Committee was the board of a leading healthcare system that didn't have the University of California name on it, it would have these very same 5 goals. Every healthcare system of scale and size in the United States is driving savings and efficiencies through scale. Every healthcare system is launching system-wide strategic initiatives, engaged in population health management. System-wide financial analysis is driven by data. So, in part, this Health Services Committee is serving kind of as the surrogate board of the Board of Regents for this healthcare delivery system. And and these goals are very consistent. Dr. Stobo, my question relates to, these goals are wholly appropriate and very consistent with what UC Health needs to do. In the strategic plan, there was a SWOT analysis. It's, for those of you tracking, it was on page 13 of the strategic plan, and it had so many strengths, weaknesses, opportunities, and threats, I found it to be a little overwhelming. And the reason I go back to that is I was trying to make a linkage between the goals and said, okay, if the University of California achieves these 5 goals, will we be addressing our weaknesses? Will be fully prepared to respond to these threats? Will we be taking full advantage of the opportunities? And frankly, there were just too many on the list to draw those those parallels. And so I guess what I'm encouraging you and your team to think about is extracting from that list of opportunities, weaknesses, and threats the things you're going to do something about. Because you can't, I mean, there's some things on that list that I just wouldn't even know where to start. You know, the one that I thought was the most interesting is that the transition in UC Health leadership is both a strength and a weakness. Now, granted, I've transitioned away from Dr. Stobo once or twice in the past, and it worked out well for me, but it doesn't necessarily make it a strength. And so I guess I would encourage us to just revisit that aspect of the strategic plan and share with the Health Services Committee what you're going to do something about. Because I don't think you're going to do something about all your weaknesses. You're not going to do something about all your threats. And if you're not, it would be useful for your governing board to know that so they don't expect you to. Does that make sense?
Yes, it does, Steve. I think the somewhat confounding variable here is that the SWOT analysis comments on the divisional office, really, and not the health system writ large. So some of these weaknesses and threats don't pertain to the health system, but pertain only to the divisional office. And they're addressed in the strategic plan only in the goal that's designed to increase our organizational effectiveness, which is not part of the collaborative budget. But there is a goal in the strategic plan that says, if you're going to achieve these goals that help the health system, you have to clean up your act as a divisional office to address some of the strengths and some of the opportunities, weaknesses, and threats that are listed on page 13.
So just to make sure I get this. So goal number 7, which Liz is responsible for, that says strengthen UC Health internal effectiveness.
Correct.
That's the goal that responds to all that SWOT analysis.
I wouldn't say all those in that SWOT analysis, but certainly a discrete set, and it is exactly as Dr. Stobo just articulated. It is, we need to be operating like a well-oiled machine internally so that we can best support the system.
So is that clear, Steve?
No, I think that's right. I think, Liz, it's an overwhelming challenge given how many weaknesses, opportunities, and threats were identified, so prioritizing them or at least culling the list so we know what you're going to get, what you're going to be working on would be a useful thing to do.
That's fair, and I think that that probably should come under the goal. And when we present the quarterly update and the goal, we can say these are the things in the strengths, the SWOT analysis that we've achieved so far as part of this in organizational effectiveness activity. That's very fair.
Other questions? Continue.
Okay, let's go to the budget. And here is our budget, 7-18 actual, 18-19, 19-20, 21-21, 21-22. The part of the budget that we want to present to you is shaded in yellow here, and it indicates the 6 goals, the budget associated with each, money that's already, that we have on hand. For the 19-20 year, in total, we're planning to have expenses of $21 million, some odd $100,000. We have roughly $11 million on hand that we can apply towards that $21 million expense. So what we're asking from the medical centers / campuses is an increment or an additional $10,287,722. Now that increment or the augmentation of our budget was discussed with the CEOs and approved, was discussed with the chancellors and approved with some discussion. And the discussion mainly among the chancellors, there were some questions about the expense, what the expenses were going to be used for, et cetera, but one of the larger topics that was discussed is how is this going to be allocated? If we are going to allocate an additional, or request an additional $10 million, how does that get allocated to the 5 campuses, or the 6 campuses that have medical centers or health-related activities? In reality, it's the 5 campuses that have medical centers. And there are 3 ways it could be allocated. One, it could be straight line allocated, 10 million divided by 5. Two, it could be allocated based on net revenue. That is, if you take the total net revenue of 5 as the denominator, the revenue of a medical center as the numerator, that becomes a fraction that you multiply 10 million some odd dollars by, and that's the allocation to that campus/medical center. Or the third is that it can be allocated based on the return on investment. That you go to the ROI and use the ROI to that specific campus as a numerator, and the ROI overall as the denominator as a way of determining the allocation. The allocation methodology has not, for 1920, has not been determined. I have to mock up those 3 scenarios that I just mentioned, present it to the chancellors and the CEOs for that discussion to occur and the distribution methodology to be decided upon. So while the distribution methodology has not been decided upon by the chancellor and the CEOs, the augmentation of 10 million, some odd $100,000 has been approved by those 2 groups. Questions?
Jack, the footnote, I think, is pretty important. Can you give us a little color on that? Because it seems to me that is one of the key benefits of us acting as a system, is the managed care contracting and the system-wide Medi-Cal work. What kind of number are we talking about there that you perceive might be achievable?
Yes, okay, I guess, okay, we can get to that and come back to the FTEs. What I tried to do in this slide, and this is the last slide, that's part of the packet, it's page 54. This indicates what we have been able to calculate for fiscal year 18, calendar year 19 in the case of the Medi-Cal, is the return of the system-wide leveraging scale for value activities. And we were able to best do this for 4. Revenue cycle, procurement, contracting, Medi-Cal. There are pharmacy savings, et cetera, that are not part of this. There are clinical lab savings that are not part of this. These are the ones we felt most confident about. In 3 cases, we were able to allocate a specific amount to a specific campus based on specific information we had as to the benefit of the activity to that campus. And this is as much of an art as it is a science, I must say. But we try to do it as scientifically as possible. For procurement, we weren't able to do that yet. We're working on it, so we just took the procurement savings for 1 year and divided it by 5. So let's pick a campus, Davis. For 17-18, I'm sorry, it was 17-18, the return for the revenue cycle that we could calculate for that year was $109 million. For procurement, it's $29 million. For contracting, what I mean by this is the incremental income to the campus that came about as a result of the incremental income we were able to negotiate in our managed care contracts with 6 commercial carriers. Health Net, Blue Shield, Anthem Blue Cross, Cigna, Aetna, and United. Now you could say, well, what value, how do you put a value on that? Well, we pretty much know what an independent entity would be able to get as a contract amount if they acted independently. And we know what we got for each campus acting as a system. And what we were able to get as a system compared to what they would be able to get on their own is significantly greater. That is, there is a value for this to our negotiating contracts on a system-wide basis. And that value is indicated in that contracting line. Medi-Cal is income that we feel fairly confident will come about in calendar year 19 as a result of system-wide Medi-Cal activities, working with the state and working with CMS and the feds. And we specifically were able to indicate the distribution methodology that was agreed upon by the CEOs. So for contracting, it's $74 million for Davis, and for Medi-Cal, it's $38 million. Now, if you look at that compared to the expenses, total expenses of $21 million, asking for an increment of 10 million, the return on investment is significant. So I think it's good evidence that the magnifying effect here of a relatively small operation that acts using professional influence and humility many times to do system-wide activities is a tremendous return on the investment. And I would argue strongly for that what we do in the divisional office to help the health systems get incremental return by acting as a system as opposed to an independent activity is significant and is good evidence that systemness works in terms of these leveraging scale for value activities. Madam Chair, there's a question.
Oh, I'm sorry. Yes. Thank you. Just real quickly, sorry, I'm just jumping in here. On the Medi-Cal figures, if you compare UCI to UCSD, the last two in that column, does that indicate the number of patients that come in with Medi-Cal? Because there's quite a disparity in those numbers.
The answer is no. It does not relate directly to the number of patients, but it's more complicated than that, and I'd be glad to go over to you. But it's not something that we decided. I did make the final decision, but based on months of discussing this with the CEOs, the CFOs, the comptrollers, etc. There was a lot of input into this, but it is not a direct relationship to the number of patients seen.
Yeah, as I read through the packet, you're I think $14 to $16 billion system, but you're not, and you're not actually, you've not been able to leverage. That would be one of the bigger systems in the country. If you look at Trinity, you're bigger than Trinity. It is now moving to 3 revenue cycles for all their hospitals. And I would just encourage you, as you look at the allocation methodology, it's always easier to get into things than it is to get out. Think about it as a future, as how whatever activities you're going to take on as a system, how you're going to allocate it, not allocate based on each individual initiative and return on investment, but look at it, in the future, what's going to happen if you're going to try and develop a UC system health plan, which might be good in unifying of all the different systems that they have a shared responsibility. But I think about it in the future, not what is the current return on a specific initiative.
Yeah. No, that's a very good point. I think there will be times when we take on a system-wide activity, which for the first couple of years may not generate significant returns, but down the road would be significant returns. Yeah.
Thank you. So I wanted to focus on the bottom half of the prior slide. 14? There we go. So obviously the big savings is on line 1, and I was wondering whether the $500 million figure that's pretty much kind of, it will level off from there. It will maintain at that status quo beyond the 21-22 period.
The answer is the increments as we get further out are going to be smaller and smaller. So after year 21-22, it would depend on a new activity coming under leveraging scale for value, not increasing the return on the existing activities, most likely. It would require a new activity.
Okay, and then for goals 3 and 5, I think that these things ought to be done regardless of what savings they yield, but I was wondering if you could talk a little bit about the modeling or the basis or the experience that you're using to put together this projection.
So for both of these, for example, for the quality and population health management function, as Regent Kiefer explained, for some of these, we're really creating something from scratch. So we've done some, some basic modeling based on, experience at the campuses, but I think we will know more when these functions are up and running. You may recall this committee and the full board recently approved the hiring of a chief clinical officer who will lead this function. So we're actively recruiting for that. So I think we will have more specific information as this function is more up and running. We have some interim work going on in the meantime, but.
Okay, so it sounds like you're not ready to share exactly any sort of methodology. I just raised the point just because it is an expense to get these things up and running, and they will provide some value, but in terms of savings, one thinks of savings as providing or not providing care that is ineffective as being the source of the savings, but sometimes more data lead to other care being provided as a result of what the data show. So I guess I'll look forward to additional information and experience really as this comes online. And then the last one, number 6, what exactly is that based on? Is that sort of getting more of the commercial payers back?
No, this has to do with making sure our existing health plans for our employees are more competitive, mainly with Kaiser. That is, we offer a more attractive alternative to Kaiser than we presently are offering.
So we will spend less money than we currently spend on purchasing Kaiser benefits?
I can't guarantee that. I can't guarantee that.
Okay, understood.
See, right now, a significant amount of money that's spent on our employee health plans does not come back to UC providers. It goes elsewhere, to other providers. Our feeling is that if we offer competitive health plans that are competitive in terms of price and competitive in terms of benefits, we should be able to increase that, the amount of money that comes back to UC providers. And one of our goals is to make our employee health plans more competitive with Kaiser.
Thank you.
Regent Park, one other point on the quality and pop health management. Of course, a key focus is getting the right care to the right patient at the right time. The other item that we're talking about is infrastructure. As the system moves more towards value, many of our med centers are trying to ramp up what they're doing in the pop health space. So we're also looking at seeing where we can do that as a system, which would generate savings so that each individual medical center isn't buying analytical tools on their own and we can collectively purchase at a lower price.
Yeah, I was going to reinforce that I'm the CEO sponsor of the Pop Health Group, and that's exactly what we're going to look to do is as we create the Pop Health infrastructure that we scale together so it's more cost effective to do it together than every single campus setting up their own infrastructure.
Regent Lansing, there was an incredibly important point just made that I don't think we should just sail over, which is there was a question asked about what happens after 21-22, when we've tapped into all the savings associated with scale associated with the existing 5/6 academic medical center campuses within the University of California. After 2022, you are going to need to produce continued savings, and the only way we know you're going to do that right now is to pursue incremental scale. And one of the things that we have struggled with as a committee over the last 4 years that I've served on the committee is that scale has come through relationships, strategic relationships and partners with systems that we don't own and haven't operated in the past. And we've talked about this a lot. And each of our academic systems in San Diego, in San Francisco, in Los Angeles, Irvine, Davis are pursuing relationships with other systems that are not owned or operated by the University of California that do bring scale. And that will happen increasingly over the 2020s, those relationships. And so this committee will be dealing with this issue continuously as to how you achieve scale without actually owning the assets that bring that scale. Does that make sense?
I mean, it makes a lot of sense. And then it brings all the issues that we've talked about, labor, reputational damage, all the things that we struggle with each time we make one of these relationships, and hope that we're making the right decisions. And only time will tell in those things. And it also raises, and I don't want to get you off track, but it also raises why we can't do it on our own. And I think that would be something that I would like to suggest, since that is the purview of this committee, to dig deeper into. Do you know, I know we brought it up before, which is what started. Obviously, we don't have the capital to do it on our own, but the question is, how can we grow within so that we can perhaps not be so dependent on these other relationships? So I'm not suggesting it be the next meeting, but Jack, I would like to have some sort of presentation on that, you know, 2 meetings from now or 3 meetings from now, at least where we are, so we can keep measuring that. Because I think that is the core issue that we're going to be facing. You know, we have to grow. Yeah. We've decided we're growing by making these partnerships, and they're the most important way we're growing. They bring with them risks and also pluses. So as we approve each one, we assess it. And then the question is, how could we grow more on our own, if at all? So I'd like to just put that forward for a future meeting.
And good points. As you know, we did have a discussion about quality and what quality metrics we're going to use to ensure that any affiliation or relationship that we have, that entity meets certain quality standards. If not, initially a given time period for which they need to meet those quality standards.
I totally agree, and I'm one of the people that has supported these votes. You know, there hasn't been a dissent actually on any of them at the moment. Right. But what as you know, maybe it's, you know, every year we see every year we see could we grow on our own without these relationships, and at the end, and then at least we keep monitoring ourselves.
No, you and Steve Lipstein are correct. We're doing all the easy stuff now, and we haven't really gotten to the real tough stuff. We're starting to. You'll hear some about that later. We didn't go over the FTE slide in the second time. Are there any questions about this? As Steve Lipstein pointed out, there is growth. Let me just say, in general, about half of our growth is FTEs that are in the divisional office in the Office of the President, and half the growth are FTEs that are out in the campus. And what I mean by that is there may be an individual on Irvine, for example, that is associated with our data activities that we would pay 100% of that person's time because the data is being stored at Irvine. At UCLA, we may ask the chief financial officer there to oversee our revenue cycle activities, and we would pay that individual stipend to do that. That is, we would pay for a portion of his time, which is usually above 100%, to do that activity on behalf of the system. And that may amount to a tenth of an FTE, or half an FTE, or 3/4 of an FTE. And so we've tried to indicate that at the bottom of the FTE slide, how many FTEs would be associated with each campus. And it's hard to get your hands around because in some cases it's one person, in the other cases it's 10 half people, or 10 third people. But the point is, I think we've been very effective without building a huge infrastructure in the Office of the President in terms of people to expand these system-wide activities. But we, where we can, use the expertise, which is substantial, out on the campuses.
Questions? Okay.
Well, any questions about any part of this? The plan itself, yes. The proposed budget, the FTE, and the calculated ROI.
No question, Jack. Just a comment that at subsequent meetings, these quarterly updates and others, it would really be useful for us to, as a committee, to know how much progress we're making against hiring the 65 people.
Yeah, no, you'll get it, and you know, it'll maybe slow at first, but and this is not. This is more than an aspirational goal. I can tell you, in terms of the Pop Health and the data initiative, we got to do this. It's not a choice, you know, and that's not something. Let's figure out how to do this over 5 years. We got to do this quickly, because as you point out, everybody else is doing it, and hopefully we can do it better.
And I'd just make a brief comment too. I think the fact that some of these FTEs are on the campuses highlights another theme that's been brought up. Are we using our campus resources and expertise effectively? And I think this demonstrates how you can use folks who are on campuses in service of the greater system.
Good point.
So you're asking about questions on any part of the strategic plan?
Yes.
Okay. I had a question on the education goals. So very happy to see this is a commitment and the thinking that's going to go behind this. I was wondering about the timing, though. I believe that there's an April 2020 date for this goal. And so is there a way to do this faster? Does an April date actually allow for a fall 2020 changes to occur? And then I wanted to also know what's the timing and the role of undergraduate education in this education plan?
I'm sorry, Regent Park, the last question?
Oh, is there some thinking about, is there an effort to think about undergraduate education as well folded into the health professions work?
Not to a great extent at this point, and that's not the educational part of our plans. Well, let me just say, you know, what's not included here is $4 million of our core budget. That core budget is used predominantly to expand our academic activities. And some of these are listed on the initial 12 goals. They're not listed here because they're not part of the collaborative. But increasing interprofessional education, for example, increasing enrollment or addressing the workforce issues, for example. Those, we have not presented those for discussion here because they are not part of this collaborative budget that comes from the campuses, the assessment that comes, additional assessment that comes from the medical schools, from the campuses and medical centers.
So what would be an appropriate place to have that discussion?
We could bring it here as a separate item. If you want, if the question is to...
Sorry.
Yeah, let me jump in here and make a suggestion, which is that I recently co-chaired a commission on the healthcare workforce of the future for California. I co-chaired it with Lloyd Dean, who's the CEO of Dignity Health. Sandra Hernandez and her foundation were heavily involved. Regent Oakley was on the commission. I think it would be useful for this committee to get a presentation on that commission report, because it does tie into pipeline and it does tie into what the University of California ought to be contributing toward the providing the healthcare workforce that California will need. So I would suggest that Regent Lansing, that at a future member of this committee, we do a presentation on that, because that'll tie Regent Park into some of the items I think you're interested in.
I think that's a good
Yeah, terrific idea.
suggestion, so why don't we schedule it as soon as we can?
We'll put it on for the next meeting. I think
Fabulous.
it's a great, great topic.
Great. Yes.
Since we will be shortly having a change in leadership at UC Health, I was just curious to what flexibility will we have going forward for new leadership to have their vision of UC Health be part of this process. We're locking into some very definite projects, and certainly new leadership brings new vision. So we want to know how much flexibility would there be to revisit a lot of these things that we're discussing today.
I mean, do you want to talk about that, President Napolitano? I mean, I'm happy to add something.
Well, I'll comment on it also.
Sure,
Go ahead,
please.
Jack.
Jack, you do,
Well,
you
first of all,
comment.
this plan is not top-down. This is a bottom-up plan. This didn't come, this is not my machination. I didn't sit in an office and say, let's do this as a goal. It came from the campuses and bubbled up by consensus to the campuses and sort of a mandate to our office. Now, occasionally we'll come up with an idea that we take to the medical centers, but it doesn't become part of our plan until it's approved by them. So that's one thing. The other thing I would say, and this is not out of arrogance, but I would say if the candidate does not buy into any of these, you probably get the wrong candidate. This is apple pie. This is not out there type of goals. These are basic fundamental things that we need to do to stay on the foundational level of competitiveness in the healthcare marketplace.
I think as Steve Lipstein, who's outside, said, you could put any name on any medical center, they would want these goals. I mean, this is like something that we all believe in. So I think what Jack said is true. I mean, it didn't come from Jack's head. It came from the CEOs and everybody participating and talking it through. Obviously, when someone comes in, if they have a good idea, the CEOs are going to respond obviously very positively to it. Other questions? President Napolitano, I didn't mean to cut you off. Did you have something you wanted to add?
No, well, the only thing I was going to add is that I actually think the search committee that is conducting the search for Jack's successor, not replacement, he's irreplaceable, but successor, should perhaps structure their evaluation and interviews of candidates to ask about how they would go about achieving these goals and their thoughts about the strategic plan.
Sure.
That's an excellent point.
Other questions? All right, then I'd like to, it's 10 or 12. I'd like to do the next item if
Sure
we
thing.
can,
The
and then break
behavioral
for
health,
10 minutes. But we're going to have a working lunch and come back and work through lunch.
Okay, I'm going to ask Brad Buckman, who is the Chief Medical Officer for Student Health Centers in our SHIP Student Health Insurance Plan, to come forward. This topic came up as a result of the previous Health Services Committee when the student advisor talked about the issue of difficulty accessing behavioral and mental health services at UCLA. And the question came to me is, what are we doing about it? And I mentioned that it's a continual challenge for us, but I thought we could benefit from a presentation by Brad, who's been deeply involved in this for several years.
Thank you, Jack.
So turn it over to Brad Buckman.
I'm not sure if I can get this mic, but I
right
can.
Here, right there.
Okay, great. Good morning or into the morning to Chair Lansing and the Regent Committee members and President Napolitano. Thank you for the opportunity to present an update on student mental health services and also to reply to some of Mr. Ramsey's comments from the last Health Services Committee meeting in December on this topic. If I am driving this, I'm going to talk a little bit about utilization trends nationally as well as within UC. I'm going to talk about appointment wait times for students to get into our counseling centers. Talk a little bit about the Student Services Fee Initiative and the achievements that our counseling centers have been able to make with that funding approved back in 2014. And then I'm going to finish up with a little bit on visit frequency, because there was a comment or two on that at the last meeting about the number of visits that students were having at the campuses, and then talk a little bit about innovations and steps forward. The first slide, this is UC data, and it's 10-year data looking at the increase in utilization at our counseling and psychological services centers, which we use the acronym CAPS. And what this slide shows that over the past 10 years, there's been an almost 80% increase in the utilization of unique patients at our CAPS centers during that decade. During the same time, the increase in enrollment at UC was only 27%, and that's what we've been observing most recently, about a just under 3% growth average growth in enrollment across the system, though some campuses are exploding and really having very high rates of growth, and others not so much. The last thing I wanted to point out on this slide is at the bottom lower right. 10 years ago, only 9% of our student enrollments came in to be seen in the counseling center. Last year, at the last full academic year, we had 13% of our students' enrollments are coming in for counseling visits. So over that decade, we've had about a 50% increase in the number of students as a percent of enrollment that are coming, and about a not quite 30% increase in enrollment. This next set of slides you've seen before, and this first slide is for urgent contact, and the upper part of this slide shows our system-wide average for the percent of patients who either walk in or call and say, I have something I'd like to talk to somebody about, quickly. And what this top slide shows is that what is the percent of students that are seen within 2 days? And this is fiscal year-to-date data over the past 3 years. With our most recent year ending December 2018. And so you can see we've had a slight decline in the average over the past 3 years, but we're still seeing 97, 96% of the students within 2 days. I will say that the majority of students are seen the same day that they call or come in. If someone is clinically very urgent or imminent, they would be seen right away. And the counseling centers are only going to ask somebody to come back tomorrow or to have that contact a day later if it's not imminent or not an immediate threat. So that shows that we're doing fairly well there, and below that are the campus-specific values on this criteria of percent of patients seen within 2 days. Any questions on that?
Yeah, what are in the bottom, the two middle ones don't have a
Yeah, I apologize for that. We've gone through these a million times, and sometimes you miss things. Merced is middle left, Riverside is middle right. Thank you for that.
One quick question. How do you define immediate or imminent? A student calls and says they're suicidal, and that takes it to a new level, but who's making the determination on immediate or imminent?
Yeah. So the definition that the CAP Centers directors use for this term or variable is just an unscheduled and called urgent by the student need. Obviously, suicidal threats are going to be seen immediately. They aren't going to be seen the next day or 2 days later or a week later. They are going to be seen that day. But what they put into this bucket for this variable is any unscheduled, unplanned visit that's either a walk-in or a call-in of a student that wants to be seen urgently. Thank you. Okay, my next couple of slides, we're not going to...
Regime.
Yes.
Since some campuses have been able, and some campuses consistently, to see 100% of students in that time period, why are other campuses not capable of doing that? Even 4% is a significant number in raw numbers of students.
Yeah.
So what are exactly the problems? Why the campuses, some campuses we're seeing worse performance over the last 3 years. Why is that?
Right. Well, I think it's multifactorial. Again, by their definition of this term, it's not necessarily something that's imminent or suicidal or of that nature, and so it's what they can accommodate. I'll show you at the end of my slides, and again, Merced is middle left there on this slide. One of the factors that is obvious in the last slide that I'll show you with their visit frequency is they're hanging on to students a lot longer. They're seeing patients a larger number of times, and so they may not have the same number of people available to see patients immediately. Enrollment growth is another clear variance. And the last thing that I think is really important for everyone to keep in mind is that the development of funding before the Student Services Fee Initiative was launched 3 years ago is highly variable, and the sustainability of that funding is highly variable. So with enrollment growth at a particular campus, the old fund's not quite keeping up with enrollment growth, salary and benefit growth, et cetera. Some of those campuses are falling behind despite our efforts to buttress them and support them more recently. So it really is a campus by campus, a lot of variability in how they're put together.
Well, I'm sorry, but what are the best practices of the campuses that are been able to, Santa Cruz, Berkeley, who have been able to meet 100% consistently? What are their best practices for doing that so that the other campuses can start getting to that level? I mean, we should be striving to have 100% on every campus consistently year in, year out.
Yeah, and again, I don't have an immediate answer for you today. We are meeting actually concurrently in this building, the directors of the CAP centers and the student health centers today and tomorrow, so I can bring that back to them. I think it's a very worthwhile goal. I think some of this data is also diluted by student priorities, and they'll come in and say, I would need to be seen urgently, and then how about this afternoon at 3? Well, I have a class. How about tomorrow? I have a class then too. As long as it's not clinically urgent or critical, then we might let that patient be seen 3 to 4 days from now if the patient agrees. So there's a lot of variables that go into this data. I totally agree with your idea. I think it's a good idea to look at best practices. That is actually why I'm in my position, is to try and get all of the centers to learn from each other and take the best from each campus and try to deploy that system-wide.
Brad, one last question. When these charts say seen, is that physically face-to-face, or does that also include telephone sessions or Skype or something of that nature?
I think it actually means either seen physically or having a longer phone call, triage phone call with a clinical psychologist. So it wouldn't be an intermediary or a support staff member would be with the psychologist. Okay, I'm going to go to the next pair of slides. This looks at fiscal year to date accessibility for counseling appointments, and my first slide is for routine intakes. And again, this is fiscal year to date data with the most recent year ending December 18, but it's the past 3 years. And you can see 3 years ago, we were able to see about 80% of the patients within 14 days. And that's when the patient called to set up the appointment. On the day that they arranged the appointment, that appointment was within 14 calendar days of when they called. That is actually very good access. I would challenge any of us to get that kind of access in the community with our own mental health providers, with our own health insurance. So we're able to get 75 to 80% of our students in within 14 calendar days. The other thing that's evident on the average slide above is that we do see a very gradual decline, and there are a number of reasons for that, but one of the main reasons is our enrollment growth has continued to be at about 3% per year over these past 3 years, and our model that these student services fee funds were based on estimated enrollment growth at about 1%. Salaries and benefits have increased, recruitment difficulties, et cetera. So we've had a little bit of a dip over time in that index. Next slide looks not at routine intake, but routine follow-up. And again, this is the percent of patients seen within 14 days. So we're at about 2/3 of patients are able to be back in within 2 weeks. There's one clinical caveat. Not every patient needs to be seen within 2 weeks. And so after an initial visit, a counselor might say come back in a month, or come back in 3 or 4 weeks, or come back whenever you feel you'd like to talk again. So this is not as good as the routine intake, and we also see, again, a gradual decline over the past 3 fiscal year-to-date data. Next slide switches to psychiatry, and first slide is for routine intakes. Again, if anyone has an urgent or critical need, they will be seen immediately as the clinician's assessment merits. We're seeing a slow decline in percent seen within 14 days for a routine intake. 3 years ago, that was about 71%, 66 2 years ago, and 63% this year. The next slide is also, go ahead, Jack. Okay. Next slide is for follow-up psychiatry, and similarly, now we're only seeing about a third of the patients within 14 calendar days. As I mentioned earlier, not every psychiatry appointment is going to have a desired outcome to be seen within 2 weeks. Some will definitely need to be seen within 2 weeks, some within 1, but many follow-up visits are going to be scheduled a little bit further out. So these numbers are close to what I showed this committee back in August, but this is with the most recent fiscal year-to-date data. And I think you can see a little bit of a downward drift. This slide doesn't demonstrate it, but a downward drift in most of the indices that we're measuring. Okay, so a quick update on our Student Services Fee Mental Health Funding Initiative. I did present this to you in August, and this has been a great slingshot forward for the CAP centers to get enough people hired to do the work that they need to do. I will say, just as an opening comment, that that funding has currently hired about 30% of the counseling FTE and 30% of the psychiatry FTE that we have in these CAP centers. This initiative back in 2014, it was approved and then launched in 2015. I mentioned earlier that the enrollment growth assumptions were at about 1% per year, and we've certainly surpassed that easily at about 3% per year. Salaries and benefits were not actually included in the model, and so we've fallen a little bit behind from that standpoint. I have mentioned in prior reports to this committee and to the regents that we did have a little bit of a glitch in this current year, and that the state did make some funds available to UC, and those were accepted to temporarily float this. Well, it was used for a lot of reasons and a lot of money. I believe it was $118 million. But I think part of those funds were used to float this initiative for a year on one-time monies. And that money would expire this June at the end of the fiscal year. So unfortunately, this 5-year program has been interrupted after the first 3 years. We have been able to sustain the people that we've hired thus far. We haven't been able to hire the remaining positions that were anticipated. I'll say that we've hired about 70 FTE of counselors, 10 FTE of psychiatrists, and so that's a total of 80 FTE out of about 93 FTE that were planned under this initiative. So about 86% of the providers that we had hoped to hire. The governor's proposal for next year includes $5.3 million in ongoing funding as opposed to one-time funding. And we certainly hope that there might be a very strong desire to use that funding to replace the fees that were anticipated for this initiative. As I've demonstrated in the slides, we really think it's important to finish that program off. But I'll be honest, I don't think finishing that program off is going to be enough for the future. We're already kind of seeing growth continue to escalate, and I'll talk a little bit in the last few slides about that. Next, I want to show you kind of what this funding was able to do, and I'm going to talk about provider-to-student ratios. The top table shows us by year the average counselor-to-student ratio, and I look back at some of our older Student Mental Health Oversight Committee reports back in 2005, 2006. We've previously had counselor-to-student ratios of 1 to 1,700 or 1,800, and we were in that range in 2014. Once this initiative was passed, despite enrollment growth continuing to kind of accelerate, we were able to lower it. In the first year, it went up a little bit to about 1,500 in year 2016-17, but got to its lowest, not in the current year, but in the prior academic year, down to 1,123. We've drifted up a smidge to 1168. This is just a snapshot to see where we are, there's an accreditation agency called the International Association for Counseling Services. They recommend a ratio of 1 to 1,000 to 1 to 1,500 for counseling FTE. Ivy League schools sometimes try to achieve a 1 to 750 ratio. The psychiatrist ratio is right below that in the upper table. The recommended ratio for psychiatrists FTE is about 1 psychiatrist for about 6,500 students or clients. We started out pretty high, but we're able to bring that down to its lowest point in 2016-17, and we've seen a little bit of an upward drift in the past 2 years. Any questions on that? And then I have the campus-specific data below that, as Regent Makarichian had requested that.
Just one question. I was just taught, Regent Lieb and I were in Merced on Friday. We met with a number of students, and this issue got brought up about the ruralness and remoteness of Merced. And on here it says that the vacancy rates are 0% for counseling and psychiatry for Merced, and yet they have some of the highest on counseling, one of the higher ratios.
Mm-hmm.
Is there an intent to hire more counselors at Merced, or is that where they are right now?
I think I am sure there's an intent and a desire to hire more counselors right away, and I know the CAPS director there, and she is adamant about it. I think this gets back to my comment a few minutes ago that while this Student Services Fee Initiative was a nice slingshot to bring people and hopefully catch them up, what it did not address is how their funding and the stability of their older funds that were there before. And so I can't account why their counseling ratio is that high with a 0% vacancy rate. They clearly need funds to support, and I think funds over and above what this initiative supplied, probably because the other funds that they initially built their center on were inadequate. Yes.
Okay.
Hadi, are you on the phone?
Yes, I am.
Okay, if you have any questions, please speak up and welcome. So we'll go with Lark and then
Yes,
Haley.
thank you very much.
Okay, I have a few questions. First, I wanted to ask about whether the campuses are doing, whether there are efforts and funding for wellness, separate from this, where students then actually have identified a mental health need per se.
Great question, and what I'm talking to is very limited to this Student Services Fee Initiative that was specifically for direct mental health providers. I would say that over my review of the Student Mental Health Oversight Committee's recommendations from 2005 on, there has consistently been an expressed desire to devote more funding to both primary prevention and secondary prevention of people with known risk factors and more targeted prevention for what we know are higher risk groups. So I don't have the numbers on health promotion or wellness funding. I would say one of the things that I was planning to conclude with is that we definitely need to move more emphasis and focus on prevention and wellness. I think there's a lot of things that are happening and a lot of things in our student environment on our campuses that are contributing to this escalating demand for services. And I think there are a variety of ways we could try to address them. We're not going to be able to out-hire this problem.
Jean, do you want to add to that? I know particularly that you have a big program.
Yeah, and I think this is true of a number of campuses. So, we have a Healthy Campus Initiative, and psychological well-being is part of that initiative. But specifically, as part of our Depression Grand Challenge, we have voluntary screening for any undergraduate who wishes to participate, and then we triage them either to online sort of cognitive therapy or counselors, depending on the needs. So I think a number of campuses are considering ways to provide screening in a preventative mode.
Many are doing online, both online screening as an option for students just when they go to their websites. Many campuses are screening during primary care visits for anxiety, depression, and alcohol and other drug use.
But also physical wellness. Didn't you have a whole eating initiative and just many initiatives? I know UCLA has, and I think many of the campuses have that. Jean, do you want to comment more on that?
Yeah, so this is really a holistic approach, and ours was actually initially established by Jane and Terry Semmel, who thought it was very important that students, that it be a total focus and everything from healthy eating to, again, psychological well-being, and many students are involved in it, and it's impacting all of campus, even it impacts the food we serve on campus. So I think this is something that a number of UCs are involved in, and we've certainly, I think it's successful.
Well, it would be great to understand what the impact, the investment and the impact of these programs are for the future. A second question that I have does also relate to a point that you made about the trend line. And so, the line ends at 1819, I believe. And so are we to expect just a further, a downward trend? And what level of investment do we need to go back up to where we were even 2 years ago?
Yeah. So I think with no action or if no further funds would be dedicated to this, then we're going to see a continued drift downward of our lead time for appointments. I think looking forward, I think we have to develop some sustainable model that takes into account actual campus enrollment growth rather than an average for the system, and the actual cost increases of care that are going on. So this was an attempt to, and I use the word slingshot, us forward to a better place with more providers on the ground doing the work, but it didn't, the prediction for enrollment growth was low, and then there really wasn't any prediction for salary and benefit growth, et cetera. So I think this has been a beautiful stopgap move to position us very, very well. And my main point is that we're beginning to see some deterioration of our very good position because things the funding has been erupted, enrollment growth has persisted. So I think we need a more comprehensive plan going forward.
Okay, are you in a position to comment on the ratios of students to psychiatrists at UC San Diego and Davis, which looked to be...
I am, and thanks for that question. So let's start with Davis. Davis actually has an arrangement with their medical center and has a number of psychiatrists from UC Davis Medical Center who are primarily devoted to their students. So that is why Davis is riding a little high. And then San Diego has an even more, UC San Diego Health is very closely interlaced with our Student Health and Counseling Center. And they have a number of psychiatry positions that are devoted to the students. They also have an office right across the street from the campus. So there are some nuances at each campus that also explain some of this variability. But for those two campuses, both of their med centers are highly collaborative with their counseling centers.
What we did at San Diego is actually the chancellor funded and the health system matched a $500,000 a year funding for the expansion of psychiatric mental health services for patients that are referred post-CAP. So eating disorders, mood disorders, et cetera, they all have access to those kind of programs, IOPs and partial hospitalization.
So you're saying that this number doesn't really reflect the service level available?
It doesn't reflect the service level. That said, it's really hard to fill these positions. So that's always a struggle, is finding the right hires, the right psychiatric faculty to do the work. So that's always a struggle, and to ramp up fast enough for the demand.
Does San Diego have a harder time than, let's say, the Bay Area or LA? Are there particular workforce issues there that aren't evident? I mean, aren't similar with the other metropolitan regions?
So I think the challenge is competing with the market, frankly, competing with the local market and being able to pay salaries and incentives that are commensurate with the competitive market.
Okay, my last question is, are there student satisfaction surveys
Yes.
available?
Yes. In the student health centers, they're done every year, and then each of our centers, because almost all of them are accredited, they perform satisfaction centers in each area of their clinic, but we also perform system-wide satisfaction surveys annually for our student health centers. Our counseling and psychological services are not quite there yet in a standardized system-wide way, but they do them individually at their campuses.
Are they available somewhere?
I have not seen the campus-based ones, but I do have availability of the student health centers. And I can certainly ask the counseling centers to forward them.
Thank you.
Mm-hmm.
Thank you. Thank you for your presentation. In a similar vein on the topic of student satisfaction, Regent Graves and I have been visiting the campuses and communicating with students, and students have been voicing concerns about quality of counseling, specifically raising concerns about whether there are enough counselors that are culturally responsive, so trained to meet the needs of specific student populations.
Right.
I'm wondering if you can give an update on any systemic conversations happening about the need to recruit and then retain culturally responsive counselors.
Yeah, so those conversations are ongoing. I did not include the data in my slides, but I did include it in my written submission for this committee report. So you guys should have data in the written submission for diversity targets that we've been able to hit with this funding source. We've been able to bring in about 89% of the targeted hires from a diversity standpoint, whether it's gender, ethnicity, language, religious orientation, sexual orientation, trauma-informed counseling, veterans issues, first-generation students, all of those. So I would say our counseling centers are very keenly aware of the need to bring in a highly diverse provider population. They're working on it aggressively, and in this initiative, the majority of hires have been within those targeted groups. Mm-hmm.
Yes, just a couple of quick questions. So going back, if we may, to some of the backup material provided in this before the PowerPoint, can you explain to me a little bit more about the student fee initiative and its allocation of funds? Did the entire special funding go to mental health? Or, as it said in the printed material, something about 50% going.
Yeah.
And if it's 50%, why not 100% since the need is so great?
Yeah. So I've used a little shorthand lately because I've been coached that using the formal name for this initiative is out of date, and I've been told that by the budgetary people at the Office of the President. The long name for this is a long-term stability plan for tuition and financial aid. It was passed by the Regents in November 2014, and President Napolitano, once it was passed, part of the underpinning of that initiative was to dedicate 50% of the funding increase for direct mental health service providers after return to financial aid. So it's actually about a third of the money, and it's only the incremental increase on the student services fee, which was about $16 per student per year, and then that was planned to happen over a 5-year interval. So far, it's happened for 3.
Okay, thank you for explaining that. I wish more could have been allocated to, in retrospect, to mental health support. And since this initiative is over, is that my understanding?
Well, I hope it's not over, and that's what I've actually been trying to try and discuss, is that I've used the word interrupted, and for a good reason. The state was willing to offer us one-time money, and that allowed us to float for a year without finding another way to do it. But I'm hoping that we will find another way to finish this off in the final 2 years. And the main reason that I've said is we've hired 86% of these providers, but we've only received about 55% of the money to do it. So there will be consequences if we're not able to finish this off in the last 2 years.
So the governor's ongoing funding will help to fill some of this gap.
Yes.
But if we continued the initiative, we could be even more successful in addressing, meeting the increased needs.
Yes, and I think the initiative was only planned for 5 years, and what I think we need to do is try to do something a little more comprehensive that's better tied to actual enrollment growth and better tied to escalating costs going forward. Otherwise, we'll fall behind again.
Thank you. I know that we're trying to get $5.3 million, and that the governor has allotted that for ongoing. I also understand that there is some pressures in the Assembly and in the Senate that would, other institutions are looking to also piggyback on some of that money as well. So, I mean, it's not a done deal yet as it goes through the budget process. So what we've talked about before, which I think is really something we ought to look at, as we see the trend lines going down and our service getting a little bit lower because of increasing demand and increasing students, is going to the individual counties, again, for the early intervention money that they have under their Prop 63. As you know, $3 billion a year goes into these counties. It's actually through the initiative passed by the voters that anybody that makes over $1 million a year, 1% goes to mental health. That money then gets collected by the state and then goes to the individual counties. The individual counties have several $100 million that they have not spent yet. They're sitting on big reserves. My feeling is, why can't we go after that money with the individual counties with our specific programs for earlier intervention? I think we could actually solve the problem if we just take the 10 campuses, the 10 counties, go and make a proposal and try to get some of that money for early intervention.
Thank you.
How do we implement that?
Yeah, we have accessed that money in the past, and my counterparts in student affairs are working on that now. We haven't in quite some time, though. So in the past, we've received monies through that program, and we certainly can look into it.
So Regent Lieb, I think in our advocacy program, this came up, and helped me a little. I think it was Daryl Steinberg that was talking to us.
And Mayor Steinberg, who's authored Prop 63, has agreed to help us with the individual counties.
So what I'd like to suggest, because this is, we discussed it in our committee on advocacy when Daryl Steinberg presented to us, and then this was brought up. I'd like to suggest that Regent Lieb and you get together and strategize offline about how to access this money. We have in Daryl Steinberg somebody who said he would work with us to help us. This is one of our highest priorities, obviously, to increase this program. You can hear that is the sense of this group, and I know you agree with it. So if you don't mind, I'd like to suggest that offline you get together.
And I would also mention, thank you, Regent Lansing. The other thing I would like to mention is that Regent Zettel and I have already set up a meeting specifically for San Diego with the Chancellor and continuing on that. And that's specific also for veterans that are affected by mental health as well. So
why don't I designate a subcommittee of Regent Zettel and Regent Lieb and you guys to get together? Because we brought this up, and I know you started to follow through on it right away with Daryl Steinberg, who was very receptive to helping us and very excited that he could help us. So let's see what we can do.
Sounds wonderful.
Okay.
I will follow up with you. Thank you.
Hadi, I have you in line, so just be patient, but I got the message. Robert May, please.
Yeah, just a bit of a follow-up. Just looking over the charts here, on most of these performance metrics, UC Santa Cruz is doing very well, in fact, as well as anyone in the system. But yet they have a very high vacancy rate for both counseling and psychiatry. So they're doing something right with limited resources. And do you have any sense of what that is that they're doing, seemingly on the whole better than other campuses?
I don't off the top of my head, but again, they're here this morning, all day today and tomorrow, and I can, I'm heading there directly after this meeting, so we will discuss it.
Okay, thank you.
Great comment, thank you. Okay, oh, sorry. Well, I can move on to another slide, or if there are other questions, yeah.
Sorry.
Hello?
Yeah, so the increase as a percent of enrollment is like 50%. You go from 9 to 13, whatever. Why? That's the big question. Do we have patient data like we do in the medical centers and CAPS that we can see the reasons why so many students are coming to us for services and address the cause? We're doing as good a job as possible. We could do better on treating the symptoms, but do we know why so many are coming?
Well, you know, the literature has lots of suggested ideas as to why. You know, this is a different cohort. They've grown up in a different kind of society. They've grown up with a lot of electronics and a lot of actually social isolation. The grading pressure is very high, so a lot of these students come from high schools with very good grades. They get into UCs. Now they're swimming with everyone else who had straight A's, and suddenly they're not straight A students anymore. So I'm worried about social isolation, and the literature suggests that, the kinds of academic pressures they're under. And then I actually worry if our institutions are promoting the kinds of environment that students would thrive in. And I worry that students often feel like our campuses can be impersonal, they can be isolating. We need to try and move beyond the walls of the clinic, and our counselors do a lot of outreach and a lot of consultation with faculty, et cetera, a ton of work outside of their walls. But how much is the rest of the campus doing to try and nurture students, help them thrive, help them really be successful academically, socially, and developmentally? And I think that's where we're falling short. But your point is, I think, that they're arriving even as freshmen with higher needs, and that is true. And I think a lot of that is societal.
Well, if I can just chime in real quick, Regent Lansing, I appreciate the comments there, but I also think one big piece is destigmatizing
I was just
mental
gonna say
health.
that.
The,
I was
the
just
academic
gonna say that.
pressures are still there. Nothing like that has changed. It's just we're having honest and open conversations that this is an issue. There's resources for folks to get help, and this is now included in faculty syllabus. And so, I mean, these are conversations that are more open, and so those are definitely reasons there, but the destigmatizing plays a significant role.
Yeah, no, I understand that, but shouldn't we know what people are coming in for and have that data available so that we could address the problems in a little bit more scientific way?
We certainly have diagnosis data, and we're actually now our counseling centers are instituting instruments that they use. It's called the CCAP survey, which measures where they are on various mood disorder scales and can assess progress over time. Anxiety and depression are the far runaway number 1 and number 2 diagnoses of our students, and anxiety is definitely escalating. And I agree that the destigmatization and the educating the faculty to send students to us when they're in trouble has been very, very successful. So that is accounting for increase in utilization. What I'm saying is there's a lot of students we're seeing that may not need a licensed psychologist to handle their problem. They might need skill building. They might need other help, either academically or socially, or feeling like they belong on campus or to a group, or they need career counseling, et cetera. So there are a lot of services. It's all being kind of funneled into one place, and what I think we need to do is get more people on campus involved in caring for the students.
How do we compare to other like universities?
How do we compare as far as?
In terms of patients as a percent of student population?
I think very similar. I don't have the numbers right off the top of my head, but all of the data that I have been sharing today is typically from these national college health organizations.
And what's the number 1 drug prescribed by the student health centers? Isn't it an antidepressant drug next to birth control?
Contraception is very high, and then if you take the generic, commonly used antidepressants and put them all together in a category, that's up there as well.
All right, thanks.
I just want to reemphasize, I do think everything you're saying is true, but the destigmatization that we have done, especially the student regents and obviously the faculty and the whole culture I think has made an enormous difference, where someone would have anxiety before, they would not tell someone, they would keep it to themselves. Now they feel very free and comfortable, which is healthy, to go to a counselor. So I think we've done a very, very good job in this area. We just need more people to help. I'm sorry, now Regent Markarician?
Yes, thank you. My question is, what is the copay that the students have to pay to Anthem, and what are we doing when they don't have the funds to pay for it? That's one question. And the second question is regarding what you were just talking about. Recently, or the past year, we've had a number of suicides, especially from Chinese students in Santa Barbara. What are we doing in getting some of these foreign students to that have problems, but they're not aware of these types of help that usually U.S. students are aware of?
So, Regent Makarici and I did recently survey the CAP centers about copays and cost of visits, and I think all of the centers, there is no copay for counseling visits. So all of the visits that students come in for counseling sessions are free. That is not the case for student health, and student health might have a $10 or $15. In fact, I just emailed UCLA after that student comment at the beginning of this meeting, and the copay for a student health visit at UCLA is $12. But for counseling visits, it's $0. So counseling visits are free. And then to your comment on suicide and certain student groups being at higher risk, we know international students are at higher risk. Social isolation, language issues, all sorts of things make it much more difficult to come to our system and go to school. There is outreach efforts that are ongoing, groups that the counseling centers are forming, anything they can do to try and reach out to these student cohorts they're doing. So we realize it's an issue. We are trying to make targeted efforts to reach out to higher risk groups that are at higher risk.
So the copay with Anthem, that's not a copay. Are you saying that you make a? I think there's a line in one of parts of your presentation that they're required to make a copay.
I think I did talk about the use of copays with regard to telemedicine and telebehavioral health services, but
what is that cost?
Typically in the $10 to $15 range.
Okay, so that's not much. Okay. All right, thank you.
Thank you.
Okay, Faculty Representative May?
Thanks. Not a question about best practices this time. But a lot of what students come for obviously are, things which are sort of short-term and need a particular care. But we do have many students who have long-term issues. Do we have ways in which we can help students transition from the care that they're receiving while students to care that they will need ongoing once they leave UC?
Yes, absolutely. So there are two issues. When a student graduates or is leaving campus for other reasons, do our clinicians know and fully accept the responsibility for transitioning care to another provider before they leave? Absolutely. So there's a clinical duty to do that. The other is that many of our students, which isn't going to surprise anybody here, they've been on medications throughout their high school career. They have serious eating disorders. They've been seeing a psychologist once or twice a week for the past 3 or 4 years. Obviously, for patients or students with very high needs, we are not able to necessarily accommodate all of those needs on campus. And so that's why we have a very close network of community psychologists and psychiatrists around each campus. And both our UC SHIP insurance, we're aware of that network, as well as each campus has built its own database on who are their best people they can refer to. So there is a good network of help of both psychologists and psychiatrists in the community. So in the interest of time, I do have a couple more slides, but I can move quickly through. Okay. Can we go back to I just want to show you guys this slide because it does get to some of the comments that some of you have made. And so this is full year data, not fiscal year to date. And what it looks at is the percentages of students who had a number of visit counts. So over on the left, upper left, purple bar is the number of students in the past full academic year who only had one visit at the counseling centers. And that makes up 31% of our students who visit the counseling centers only had one visit. The next bar to the right is the one who had the number of students who had two visits, and that's 17%. So I mainly wanted to point out that almost 50% of our students who are seen in CAP centers are only seen once or twice. There may be some opportunities there to think about, well, what do they need? Could that be provided by someone else on campus? Could it be provided another way? My next slide, I'm just gonna, if we could just roll to it, this is in your written submission as well, talks about technology options that are in use at many of the campuses. Screening is set up at almost every CAP center's website. A number of campuses are using digital programs to offer therapy. I do have a little bit there on telemedicine in the middle, and I just want to highlight a couple things. Merced does not have any psychiatrists in the county. So Dr. Boggs, who runs the health center, has through a lot of initiative and grunt work, has been able to set up a telepsychiatry platform at UC Merced that uses a group out of Fresno. That's why their psychiatry ratios are very good, because they're a small campus, and they're paying for up to 40 hours of psychiatry time there per week. Our UC SHIP insurance program does have a telemedicine platform called Live Health Online, which has both medical and behavioral health components. And then Dr. Friedman at UCSD and the Center of Excellence for Telemedicine at San Diego has a proposal that he has spoken to us about for telepsychiatry, in which we would use UC faculty, psychiatrists and psychologists. He is interested in making those available to student health and counseling. His proposal does need some seed funding. He's looking for about $500,000 to try and get that off the ground. But we are eager to see if that's something that we might be able to use as a way to further enhance our psychiatry and possibly counseling coverage for our centers. You can go to the last slide, Jack. So in summary, I thank everybody for their comments. This is as Dr. Stobo said last month, a vexing problem that we're really trying to address. I think one of the answers has to be an even greater emphasis on prevention and wellness, and creating campus climates that are nurturing to our students, that they can thrive in academically. And I think, UC campuses are tough to get in. They're swimming with everybody else who have been stellar in high school, and the pressures on our students are intense. And to be honest, I don't think they're as equipped now as they were 10 or 20 years ago to deal with those pressures. And so we have to try and surround them with more help. The other thing I want to emphasize is, over the course of the summer, there's been a lot of discussion with the UC Health Advisory Committee and the reporting lines for student health and counseling. I've already begun working and had for the past 2 years with student affairs, but I think now more than ever, it's really critical that we get a multidisciplinary leadership team together, both student affairs, academic affairs, UC Health. We need campuses from the ground up to really take this as a priority. And it's great that we've reduced the stigma and referring students at record paces to our counseling centers. Now we need the rest of the campus to try and say, what else can they do to try and fully support our students in the environment that they're working in? So that's it. Thank you very much. Any other questions that anybody might have?
Yeah, I was just going to follow up on your next step slide, and I think you've captured a lot of what this committee is concerned with. I think that one of the things we need to do is think about with the chancellors a multidisciplinary approach that unites kind of the wellness activities on the campus with the actual provision of mental health services. And so I'd like to work with you in terms of, well, what would that look like? And what would your recommendation be for what that would look like so that I can talk about that with the chancellors? I also think this funding issue needs to be addressed. And so I think as a system, we ought to really explore this Prop 63 option, even as we advocate for the governor's budget, et cetera, et cetera. It seems to me that if there is funding there, this is what it's for. And we should really take that on as a charge. So I'd like to ask, you and your team, we can work with you with our state and government relations folks, whatever, but let's really try to pull that together and put some energy behind that.
Sounds great. Thank you.
Thank you, President Napolitano. I'd like to call student observer Ashraf Bashay, who is going to give us what's really going on, I guess, from your point of view, from the students' point of view. Thank you for your patience. I know we're running very behind, so I appreciate you staying.
Of course, my pleasure. Good afternoon, Regents. First of all, I'd like to thank Chair Lansing, President Napolitano, and all of the board and the committee here for being steadfast in addressing the issue of mental health support. This is a very, very urgent issue that has great implications on our students across the UC. And I think a lot of the points that I had here in my speech have been addressed and discussed thoroughly. So I don't want to be redundant, but there are a few things that I want to highlight so that you understand what is central to this matter at hand for further consideration and discussion. I'd like to take a minute to kind of explain the multifaceted issue at hand. First of all, the funding model that was in place for mental health services, the trajectory that was supposed to be taken by the UC is the 5-year plan, an increase of student services fees. With that 5%, half of it would have been allocated to mental health support, Tier 1 specifically. And so with the recent $5.3 million ongoing fund that is being proposed by Governor Newsom, this essentially, that was proposed, that is, my apologies, the $5.3 million that was allocated by Governor Brown last year, that essentially led to us pausing the 5-year plan. And so now we are in a position where we need to understand that if these funds are not continued in the future, we will be at a deficit of around $5.3 million. And so we need to find a replacement for the temporary funding that allowed us not to increase the student services fees this past year. Another part that Dr. Brad and Dr. Sobo have highlighted is that the model that was set in place anticipated that we would have a 1 to 1.2% increase in enrollment because of agreements that were had with the governor and issues surrounding tuition and trying to limit any increase on that. The enrollment has exceeded that expectation, and so it's important for us to make sure that funding for mental health services continues to keep up with the enrollment growth that we have. Now, more specifically, I also wanted to highlight 2 other priorities that I have in mind. As great as it is to talk about mental health on a broad level, it's important to look at the specifics of the programs that we offer and the different communities that might be particularly vulnerable and in need of mental health support. Several students came today to speak in public comment and talk about the program CARE, which stands for Campus Assault Resources and Education. It is so crucial for us to understand that the 3-year funding that was implemented is now expiring, and we need to be very thoughtful in terms of seeing where we can replace that funding that is expiring so that we can continue to support student survivors deal with mental health issues. Also, in discussions with the UC Student Association and President Napolitano, there was a commitment made to investigate the mental health needs of undocumented students in a time where this population is really relegated to the margins and feeling particularly stressed in this political environment. We need in-depth analysis of what those needs are, the level of the needs, and how we can be proactive in addressing them. Also, a couple of other things that came up in the conversation is the issue of stigma. Yes, and I think this is a major part of what is happening now in the United States, is that we are destigmatizing mental health, and that is something that we should be proud of. The second level to the conversation is how we can meet that need. I am particularly reminded of my international identity as someone here in the UC from a different country. I am from Egypt, and I also serve as an international officer UC-wide. And I've had several conversations with members of the international community who have really expressed that they don't feel like they can connect with members of the CAPS centers. And so having culturally sensitive therapists in these centers is very, very crucial. One statistic that was shared with me in the past is that 50% of international students who utilize CAPS were referred from ER to CAPS. And that speaks to the level that we allow our mental health to aggravate to, for us to really appreciate the importance of prioritizing our mental health. And so I would really recommend that not only we look at the funding model at a broad level with the ratios, but understand the variations that can occur within our communities, understand that there are certain campuses that are more vulnerable than another, and really conducting that in-depth analysis and engaging with campuses and student communities to listen to them, to validate their opinions, and to address those needs as best as we can. So those were the majority of my remarks, but also I wanted to highlight the importance of seeking Proposition 63 funding. 76% of our students are residents of the state, and one of the things that we keep saying is that their families invest taxes into this university, and so it's important where we can to utilize these funds to support mental health across the UC. And I want to make sure that as we pursue funding, we always keep in mind the disproportionality that exists across the UC between the different campuses in terms of need and vulnerability, because it's not all standard, and sometimes the numbers don't reflect the qualitative experiences of our students. So I wanted to thank Dr. Stobo and Dr. Brad for engaging with me, sharing the scope of the services, the recent developments, and the future trajectory of mental health services, and I really look forward to engaging with you inside and outside of the meeting. Thank you, Chair Lansing.
I actually am delighted by your report that you feel that we covered most of the things that were of concern to you, so that's great. And I appreciate you being here. I appreciate an update as we have from our student regents and from you in particular. It means a lot to us. So I think this was a really great report, and we've, I think, taken some really constructive actions that we, organized to move forward on. So I'm very pleased with this because it is one of our biggest concerns as regents. I'd like to take a 10-minute break. I know it'll be a little longer, but let's go get our lunch because we're about an hour behind. Okay?
Have you met? I have not yet. We had a long conversation.
Good to see you. Thanks so much for your comments.
Absolutely.
Presenters, wait a minute. Who's next? I'll go around now.
I don't know.
Okay, so here comes Robert Cherry also. So your presenters are back. So they're set.
So I think if we can have a working lunch and we can all eat and continue, even though we have, because of time, we're postponing item H7, which will, Jack, as courtesy to the people that flew in, perhaps that can be our first item on our next meeting, because we had a group of people that flew in to present it, but you're saying that we can postpone it till the next meeting, correct?
That'll work fine, right, Mark?
So we'll postpone it and we'll start with them so it won't happen twice. But they were very generous and kind. So let's move on to item H5.
Well, Rob Cherry, who is the Chief Medical and Quality Officer at UCLA, on behalf of the system-wide Chief Medical Office and Chief Nursing Office, will present an update on the collaborative physician well-being.
Thank you, Dr. Sobo. Regent Lansing. It's It's a pleasure to be here to address the Health Services Committee again. I wanted to, before I address the issue of wellness, which is on the topic for H5, I just wanted to briefly just follow up on a couple of items from prior conversations that we've had. First of all, in your packet is the dashboard, the quality dashboard. I just wanted to mention specifically the hospital-acquired pressure ulcers, because we had a discussion about that a couple of meetings ago, in which there's a chief nursing officer group that's collaborating around this particular issue. As you may recall from our discussion, there was a lot of fluctuation and variation among the UC medical centers with respect to this particular metric. After a lot of discussion amongst that group, they decided to change the benchmark from what's called the CalNOC data to our Vizient data, and Vizient is the driver of much of the data that you see in the quality dashboard. The advantage of the Vizient data is that we're much more confident in the measure. It's clear, it's consistent. It's also a rolling 6 months, so there's less variability. And it's the same person taking the data on the same date, so it allows for easier comparisons. And perhaps most importantly, unlike the CalNOC data, where it's a prevalence study. In other words, what is the number of ulcers that you have on a particular day in your institution? This is actually the incidence of the total number of pressure ulcers that you've had over the entire quarter. So what you'll see on that dashboard is actually less variability between institutions, which allows us and allows that collaborative in particular to have much more strategic discussions in terms of best practices, where to share them at, and how to provide scale. So I want to mention that. And then in our last discussion, we talked about physician disruptive behaviors, and that was a very constructive discussion that we had. Just in follow-up to that, there are active discussions going on with Dr. Sobo, the deans, the CEOs, and the CMO, CNO group regarding the UC Health leadership meeting that will be happening in April. And so there's active planning going on regarding carving out some time for that particular meeting to discuss disruptive behaviors, perhaps inviting outside speakers, having a panel discussion, an opportunity for learning and sharing, and perhaps determining some collaborative next steps. So I wanted to close the loop on those two items, and which is also a good segue into our next topic. But I'll just pause here for a moment in case there are any questions regarding those opening comments. Seeing none, I wanted to talk to you about physician wellness, which is a really significant issue. As many of you know, and we did discuss on it regarding our disruptive behavior discussion, it's reached a crisis point in our country where up to 1 out of every 2 physicians, for example, may be suffering from one or more symptom of burnout. And so the fact that many of our clinicians, and not just physicians, may be suffering from a lack of resiliency and burnout, and just their own mental health may not be as well as we would like it to be is a challenge all over the country. And as we know, what that leads to is really poor morale within our institutions, high turnover rate, and it can have an impact on safety and clinical outcomes as well. And we sometimes do see that in terms of medical errors and increased liability for organizations all over the country, not just UC Health. And so there's been more and more discussions about the issue of burnout among our clinicians, among various different groups within the organization, which includes our deans, our vice chancellors, our CEOs as well, because of the increasing concern that we have around physician wellness and clinician wellness overall. And so this has led to the deans and the CEOs collaborating also with the CMO, CNO group to also get some additional input in terms of touch points for collaborations and tactical strategies for next steps. And this has really led to a really fruitful discussion in which there's a collaborative that's going to be launched around physician wellness. And I think this is a really great next step for UC Health in terms of addressing this particular issue. And it will be composed of various stakeholders, but particularly those people that are expert in wellness and are actually doing the work within our respective medical centers are going to be the individuals that actually will be participating in this collaborative. And that includes Davis Irvine, Los Angeles, Riverside as well, San Diego, and San Francisco. I should mention that Dr. Josh Adler, who is part of our CNO group, as well as Catherine Nation, will serve as executive sponsors with the collaborative. We've recently decided as a CMO group that when these new collaboratives start, there's somebody from the group should be part of an executive sponsor for these different collaboratives. So we thank Dr. Adler for being so much involved with all of this as well. The CNO group will serve as, for lack of a better term, an executive liaison, knowing that there are multiple stakeholders in this, particularly the CEOs and deans, as well as the academic senate and others that are involved. This particular collaborative will be co-chaired by Dr. Tom Savides at UC San Diego and Diane Sleva at UC San Francisco. Our faculty representative at the Health Services Committee here, Stephen Hetz, will also be part of this collaborative as well. And so it represents, again, an opportunity to really have cross-campus discussion in terms of where the opportunities are, and to also make sure that that body invites others that have a vested interest in this particular topic as well, because there are many that range from the academic senate to HR to Title IX that also have a real interest in making sure that we put our best foot forward and serve our clinician workforce well. There are a couple of main objectives regarding the collaborative. The first is really to assess the current state within our medical centers. How are we assessing physician wellness in particular, what interventions are being done within our local medical centers. And the second, which is related to this, is also to take a look at what our current practices are for mitigating against disruptive behavior. Although there are different issues, what we do know is that physician wellness can be a significant contribution and exacerbation of different disruptive behaviors within our organizations. And so they'll be looking at those two issues in collaboration. One of the things that they'll do with regards to wellness is really identify the areas for collaboration, because there are many stakeholders, as I mentioned, that are involved with this, to really identify the best practices and to see where the effective interventions might be to have impact. Most of all, to really see among those best practices what can be leveraged to provide scale across UC Health. At the same time, during the course of those discussions, is anticipated that certain hot topics will come up that should be escalated to UCOP leadership as well. In addition, because we are an academic health system, opportunities for research and opportunities to really advance knowledge in the field will also be discussed and looked at as well. And the deans are also very concerned about the implications of this work for medical student education, as well as the training and learning environment for residents and fellows as well. In terms of disruptive behaviors, we'll be looking at the same thing, which has to do with looking at our current practices and really what are the different avenues and channels that we can integrate in a cohesive manner to be able to mitigate against disruptive behaviors. And again, look at the best practices and where there's opportunities for scale, not just among our attending staff, but also how we can help medical students and residents as well. So there will be a number of deliverables coming out of this particular collaborative. One of them is really just an overall assessment of how we're doing at each campus, what tools that we're actually utilizing to assess burnout and resiliency among our physician staff, and how we're interpreting those particular findings within our campuses. The other thing that we want to understand fully is what's the organizational structure within our campuses for dealing with burnout. We know that every campus is actually working on this, but how the different efforts are actually being resourced and organized would be helpful to know as well. And then, based on all these learnings, to really come up with a set of findings and recommendations for physician wellness and for mitigating against disruptive behaviors. It'll be helpful to actually, there'll certainly be a lengthy list of recommendations, but to really prioritize those in the order of impact and provide also some early and preliminary recommendations for the leadership retreat that will occur in this coming April. We hope that at the end of the day, we'll have a comprehensive toolkit that can be delivered to each campus that can be sufficiently customized based on their local environment to decrease disruptive behavior, but also enhance physician wellness. So I'll stop here for questions about that collaborative. And Dr. Sobel, if you have any comments, you can feel free to add to that.
Just real quickly, I thank you for your work here. It's troubling to see an important part of our university family to be so distressed and so stressed, and your work is so very, very important. So hopefully we can get more of a less burnout and less stress for the profession, for the residents and students. Thank you.
Yeah, thank you.
I don't think it's us alone. I want to be clear about that. I think that physician burnout and, the new healthcare regulations and the amount of paperwork and things that are going on are causing it. So I think we're not unique. Perhaps we are, I don't want to say unique, but we are really addressing this as a high priority and making it quite serious because it does affect patient care.
Right, and we're not unique, and I hate to really oversimplify, the problem, but it really is in three buckets. One is feeling valued within the organization, making sure that there are appropriate reward and recognition programs for physicians and other clinicians as well. And then there are a lot of operational challenges, whether it's the electronic medical record or just making sure that patients have access in a timely fashion to their clinic appointments so they can make decisions about their patients. The operational challenges tend to be contributing to burnout as well. And then the other aspect of it is how do physicians take care of each other and themselves, and to allow themselves to really decompress and be re-energized for the workday.
Okay. If there are no, sorry, yes. Talk a little louder, please. I don't think the mic is on.
Okay. What about now?
Yeah, perfect.
Okay. I just said that I was working with Physicians for a Healthy California in conjunction with the California Medical Association. Their aim was to assess physician burnout in women of color. And because I was representing UC, I was able to convince them to look at all women, and I enlisted through the deans representatives from each campus. Therefore, we have sent out a survey inclusive of women within the UC system. We're in the process of analyzing that data, but the assessment was developed based on experience of several experts, people from Stanford who've done some work in physician burnout. And to the extent that what we've done may be able to assist and inform your work group, please let me know.
Oh, yeah, thank you. That's extraordinarily helpful because we do know that different physician experiences they may have different, outcomes given their unique experiences within the healthcare environment. And there are different tools and instruments for measuring, burnout and resiliency and decompression, and they're not all the same. And certainly being able to differentiate and target certain groups that may be most vulnerable and at risk is a helpful contribution. So thanks for mentioning that, so we can consider that tool as well.
Regent Park?
Thank you. Could you reiterate the timeline of the collaborative's work?
Yeah, so the collaborative is going to be launched fairly quickly. This team is probably going to be getting together within the coming weeks. And one of the first things it'll be charged with is really kind of reviewing the charter and understanding what the timeline will be in terms of meeting certain types of deliverables. I think the first and most immediate one is providing some sort of guidance with the leadership retreat that will come within April. But I think it will take a little bit of time to assess the current state, knowing that we're all doing things differently, and how do we, in a really comprehensive way, be able to make a comparison across the UC system, knowing that we may be using different types of survey tools to assess physician burnout and resiliency or decompression. So hopefully, probably in about 3 months, we should start really seeing the first of the deliverables, though.
And when will you be coming back to this committee?
I think probably the most appropriate time, I'll defer to Dr. Stowe, will be sometime after the leadership retreat, because they'll be sort of more informed and enlightened.
I'm transferring Regent Macarisio.
About the scope and the extent of the problem, and the work and the collaborative role already have been meeting, and it'll be an opportunity to be able to combine that discussion with the collaborative discussion and come back to this group with more information.
Faculty Representative May?
Yeah, thank you. So this issue, of course, ties directly to the abilities of the medical centers to carry out their academic role and provide medical education as well. So I was just wondering what role you see and to what extent the faculty in the Academic Senate will be represented and have their voice on this committee.
Yeah, there's been discussion about the diversity of stakeholders that are involved, both on the school side and on the clinical side, because if you look at an individual physician, their clinical activities, their educational activities, their research activities are bundled, and people don't necessarily bifurcate those things cleanly during the course of the day. And so we do know that looking at the individuals that are represented, because they are doing wellness work within each of the institutions, they know, I think, very well how to bring in the respective stakeholders within their local environment. So we're going to really defer to the group and our executive sponsors, Dr. Adler and Dr. Nation, to facilitate open bidirectional communication with those that have a genuine interest in this, so that we can really move forward.
Yeah, well, I appreciate that, and but there's a difference between communicating with the faculty and having faculty representation on the collaborative group.
Yeah. Mm-hmm.
Okay. Thank you.
Thanks,
very much, and we will look forward to hearing back from you.
Thank you.
We have one more item before we go into closed session. It's just the overview of the Parnassus Heights planning in San Francisco. So Chancellor Hargood and Vice President Stobo and Mark Larratt, CEO, will present this to us.
I'll ask Chancellor Hargood to start off.
Thank you, Chair Lansing and committee. This is the first really orienting meeting that will be followed by several meetings over the next 2 years to introduce you to our planning efforts for a major new hospital on the Parnassus Heights campus, along with our plans to revitalize the overall Parnassus Heights campus site. Parnassus is our oldest and largest site at UCSF, and it is the home to our 4 professional schools, various research programs, and our adult specialty hospitals and clinics. After gaining widespread philanthropic, civic, and community support that enabled the development of the Mission Bay campus, we are now turning our attention to revitalizing the historic Parnassus Heights campus. Half of the buildings on the campus are at least 50 years old, and the lack of investment in the Parnassus Heights campus has led to a deterioration of the physical infrastructure and concern amongst the faculty regarding the future of the campus, leading to problems of recruitment and retention. The Parnassus Heights campus as a whole has grown incrementally over more than a century, and it lacks a cohesive identity with no recognized campus heart. The current clinical facilities are outdated and require expensive maintenance and repair. In addition, the Moffitt Hospital must be seismically retrofitted or decommissioned for inpatient acute care by January the 1st, 2030 to comply with state seismic regulations. Given all of that, we have embarked on two major parallel and coordinated planning processes that we believe will result in a transformative vision to ensure that the Parnassus Heights campus site remains a flagship site for UCSF for generations to come. These two major parallel planning efforts are first the planning for a brand new hospital on the Parnassus Heights campus, and secondly, a comprehensive Parnassus Heights plan. About a year ago, we launched a planning process to re-envisage and revitalize the campus as a whole. The resulting plan, which we call the Comprehensive Parnassus Heights Plan, will be an essential tool to help guide decisions regarding new construction, demolition, and renovation over at least the next 2 decades. The Comprehensive Parnassus Heights Plan is intended to provide flexibility to allow us to adapt and respond to unanticipated opportunities and needs in the future, including the incorporation of a major and larger hospital. Scenarios for an initial phase of Parnassus Heights improvement are being developed, along with a framework for future phases of revitalization. One of the guiding principles of the plan is to form complementary districts that can help organize functions to reinforce identity, improve operational efficiency, and facilitate collaborations. And these regional identities are shown on this slide. The districts identified would be supported by a series of concourses to provide clear connections and strengthen wayfinding. These concepts foster convergence of the academic, clinical, and research missions. A major element of our long-range renewal planning is the construction of a new hospital, and we are fortunate to have received a generous $500 million commitment from the Helen Diller Foundation to support the planning, design, and construction of a new world-class hospital on Parnassus Heights. The proposed new hospital is planned to be constructed where the Langley Porter Psychiatric Institute is currently located, outlined in white on this map, in the clinical East End district. This location, it's actually colored purple on this map. This location would provide critical connections and adjacencies to the Long and Moffitt hospitals, optimizing the delivery of patient care while also fostering connections to the research and academic communities on the Parnassus Heights campus. The outpatient psychiatric services currently located in the Langley Porter Psychiatric Institute will be relocated to the Child, Teen, and Family Center and the Department of Psychiatry building at 2130 3rd Street, located 1 block south of the Mission Bay campus site. This building is under construction at the present time. The inpatient and partial hospitalization programs will be relocated to an alternative space. Discussions are actively underway to identify the appropriate location for these inpatient programs. The Parnassus Heights campus is critical to UCSF's future, and this planning process is intended to assure our excellence in research, education, and patient care well into the future. Over the last 10 years, the Bay Area population has grown steadily by about 1% per year, and substantial growth is expected to continue at a similar pace over the next 5 years. With national Medicare enrollment expected to increase over the next 10 years, we also expect to see an increase in the acuity and length of stay of our patients. We are also planning to accommodate more complex cases in the hospital as less complex cases continue to migrate to the outpatient care facilities. This will mean a longer length of stay for each admission and are driving our projected bed needs. We continue to work closely with our regional network partners and affiliates who rely on UCSF to support their complex patients, and the demand for patient transfers to UCSF continues to grow. In 2017-2018, we underwent a strategic clinical facilities planning process to develop achievable and affordable facility options that would align with these volume projections, our long-term strategy for UCSF Health, our business plans, and our financial capabilities. The conclusion of this planning process was that a larger hospital is needed on the Parnassus Heights site than what had been envisaged in the 2014 Long-Range Development Plan approved by the Regents. By investing in our facilities, UCSF Health is investing in our patients, providers, and staff by creating more inviting, functional, and state-of-the-art buildings in which to provide care. This is just a snapshot of January 31st of this year, the midnight census, indicating that our hospital on Parnassus Heights is currently operating at capacity. This slide shows that of the 456 available beds, 97% were occupied at midnight on January 31st, and with the planned admissions and discharges, there were no empty beds planned for the following day, leaving 14 patients in the emergency department waiting to be admitted. And this is the status of the hospital day after day, even now through the weekends. This census is reflective of the care that we provide, but does strongly indicate a larger hospital is required. Parnassus Heights is the center of the vast majority of our adult clinical care, and this is not expected to change under our planning. Hospital discharges for many services such as neurosurgery, vascular surgery, are expected to see significant increases over the next 10 years as a result of both growth in population and the percentage of Bay Area residents reaching Medicare age. It is critical, therefore, for us to replace and expand our inpatient adult care services on Parnassus Heights. The clinical facilities are aging, undersized, and functionally obsolete. There are also seismic drivers for the hospital replacement. In addition, we need to stay competitive in a very competitive marketplace, with both Stanford, Sutter, and Kaiser recently replacing their clinical facilities. In 2018, a vision and guiding principles for the planning and design of the new hospital at Parnassus Heights was developed. Based on this visioning work, master planning and functional and space programming for the proposed project is planned to begin this spring and continue into the next year. The planning and programming for the new hospital will be developed in the context of functional needs across the UCSF Helen Diller Medical Center at Parnassus Heights, and it will include the future uses of Long and Moffitt hospitals. The design, we are planning the architectural design to begin in 2020, with site clearance work in 2022 and subsequent construction and financing to begin in earnest in 2023. And we are targeting 2029 for the first patient in the new hospital. In December, we plan to come back to this committee with more information about the proposed hospital project, followed by discussion and a request for preliminary plan funding in subsequent meetings of the Finance and Capital Strategies Committee. We also plan to provide updates as planning efforts for Parnassus and the new hospital continue. This concludes my prepared remarks, and of course, I'm happy to answer any questions.
Regent Markarishian, I believe you had a question?
If he doesn't, I do.
All right, well, I'll start with Steve then, and Regent Markarishian, if you come back on the phone, let us know.
So, Dr. Hallgood, I think I understand where the new hospital would go, but one of the ways that health systems afford new infrastructure and replacing existing infrastructure is demolition. So if all we do is add new buildings, but we don't take down the old buildings, we increase our operating costs, obviously. So as part of this comprehensive planning that you're going to do for the Parnassus campus, do you envision repurposing all the old buildings, or do you envision a serious program of demolition so that you don't have to continue to finance those old buildings and operate things that are, structure that's no longer efficient?
Both. The comprehensive plan is not yet completed. It'll be completed this summer. For the hospital project, we will be demolishing an existing building, the psychiatry building, and building a much larger tower on that site. The plans for the decommissioned Moffat Hospital, which can be seismically retrofitted for non-inpatient care at a relative affordable price, we are in the planning stages right now. Clearly, it cannot be demolished until the new hospital is built, because we have to operate the hospital through the construction period. So that would be post-2030. But that's one of the reasons we brought in a comprehensive planning architectural firm to help us design the entire site. A couple of the buildings, although not Moffat Hospital, while they are not yet registered as landmark buildings, there is some community support for us to maintain. For instance, the oldest building on the site, which was the very first UCSF hospital, which was opened in 1917. So we're balancing all of those issues and working with the community right now, but your point is well taken.
Yeah, I think the concern I would have is that facility planners, master planners, are space planners, and Moffitt and Long hospitals are sources of space, but they're also going to have to be paid for long term. And if you're paying for a new hospital and you're also paying to operate the old hospitals, it's just very expensive.
Yes. Long Hospital meets seismic 2030 requirements, so Long Hospital can remain open. To replace the entire complex would be both probably physically impossible on this site, as well as probably financially beyond us, but we are studying all the options right now. Yes, David?
Just to follow up, it would seem to me that it would be nice to see the facility condition assessment as to, what is the deferred maintenance and what the costs are, and whether, these buildings are at tear-down status. They may meet seismic, conditions, but I would, we look at it from the perspective of whether these are now tear-down and they're too costly to operate, just to follow up with Steve.
Right.
And I think just to build on that, Sam, will the Moffitt space, for example, be utilizable for non-clinical purposes? And I think the answer is yes. For example, will it help alleviate some of the off-campus leases that we currently hold?
Yes, it's possible that some of the hospital support spaces, including, for instance, diagnostics, near and dear to your heart, as well as perhaps clinical pharmacy, could remain in Moffat Hospital and dedicate the new hospital to patient care activities. But that's we're just hiring the programming architects right now, so we'll work through all of that over the next several months.
Regent Markarishian, are you on the phone?
Yes, I am.
I know you had a question on this.
Yes, I did. First of all, Chancellor Harwood, congratulations and thank you to Helen Diller Foundation for the $500 million. I have reading your item, the 3.67 million square feet was a limitation that was set in 1976 by the regions. Is that something that regions have to readdress, because obviously the need has grown? And are there any other agreements that are in place that limit you to that square footage? That's number one. And number two is that you had stated that, or stated someplace in there, that the residential may not be subject to that ceiling. Are you planning to put in adequate housing for the students and staff in your planning? As you know, the San Francisco is very expensive, and with the traffic and all that stuff. What are your plans in those regards?
Yes, so to take the two questions in order, in 1976, the Regents did pass a resolution limiting the total square footage that we could have as structured space on the Parnassus campus to 3.55 million. At that time, it included residential student housing. We are currently at 3.665, about over the space ceiling, but in 2014, the Regents amended the 1976 resolution to exclude housing from the calculated total. We will be bringing back to the Regents an item probably in the summer or fall to help us think through the space ceiling implications of the current 2014 long-range development plan in order to facilitate the larger hospital that we feel is now needed, as well as academic expansion and growth. And we're working closely with the community and elected officials, both locally and in Sacramento, to prepare for that. Your second point, are we thinking about housing on this site? Yes, that's a major focus of the site planning that is underway now. Right now, the focus for housing on the site is what on the second slide is labeled as the west side, which is closer to the suburban residential community, and we believe we have a very exciting opportunity to build both significant housing for students, faculty, and staff on that site.
Other questions?
So there's no limitations on the square footage or number of units?
There is no housing is no longer included in the space ceiling, so the limitation would be what we could negotiate with the community and with the city's owners. The area is clearly zoned for residential. Yes.
Thank you.
Other questions? Oh, Sandra, I didn't see you. Sorry, I apologize.
I snuck in, that's why you didn't see me. Hey, Sam, I just wonder, in this planning process, what ends up happening net to the psych beds that are going to be moving from Langley Porter to Mission Bay?
So the outpatient activity is what's moving to Mission Bay, and there will be a significant expansion, almost a threefold increase in total space for outpatient psychiatry. The inpatient unit, which right now is a relatively small unit, and the outpatient day hospital will be relocated from the Parnassus campus to a number of options that we're studying right now. We're not building inpatient beds at Mission Bay. We're studying where the inpatient unit will be relocated to, and probably it will be a modest increase in size. But we're working with the mayor and others on what the overall need in the city is.
Then, thank you for.
Thanks, Ann.
And I think we're going to move into closed session now, Jack, is that correct?
Correct.
So give us about 3 or 4 minutes, and we'll move into closed session. And thank you again, all of you, for attending the public part.